Everyone can take their seats. It's good to have a full house and a full crowd. So welcome to the Chicago Council on Global Affairs' third International Women's Day Global Health Symposium. In 2009, the Council made the decision to develop a stream of programming that would feature leading speakers on global women's issues of today and tomorrow. What started really as a very small discussion series has grown into 7 major events each year featuring speakers such as Hawa Abdi, who fought against al-Shabaab and protected over 90,000 people living on her land during the Somali Civil War. We had Madeleine Albright and Milan Verveer, who discussed women as change makers on the occasion of the NATO summit here in Chicago in 2012, a meeting I well remember. And Lema Bowie, who joined us before she won the Nobel Peace Prize and shared her story of women peacemakers in Liberia. The warm welcome each of these leaders received confirms that there is a very vibrant community here in Chicago that cares deeply about these topics, and the contributions you make to these conversations are appreciated. And that's a good warning. Could you please silence your phones before we go any further? Because I just did. Today's Global Health Symposium is another installment in our programming on women. I'm very much looking forward to the ideas that are generated by our discussions here today, by the speakers, our moderators, and those of you who will be part of the conversation. We're very fortunate to have not only your support by joining us today, but also the support of 2 sponsors who've helped make this symposium possible. I want to recognize them here at this moment. AbbVie is now in its 2nd year as a lead sponsor. As most of you know, AbbVie is a global research-based biopharmaceutical company formed in 2013 following its split from Abbott. And they are very much engaged in the conversation on women's health. We're grateful for their sustained support of the Global Health Symposium and indeed of their sustained support of the Chicago Council writ large. This year, USG Corporation has signed on as well as a co-lead sponsor. USG are leaders in the building and manufacturing industry and have done much to contribute to women's health in the workplace. We're very fortunate to have their involvement and support here today. We're also extremely grateful and pleased to have partnership of 25 nonprofit institutions that are each focused on different aspects of women's health. We thank the representatives of those institutions who have dedicated their time and ideas to making this symposium possible and what I am sure will be a great success. If there ever was a council program that is on the record, this is one. This is it. We're live streaming each panel, and we encourage you to join the online conversation through Twitter, Facebook, or any other social media platform that you use, as long as you, as I said, silence your phones. We will follow the conversation all day long. We'll incorporate the ideas that are generated by this conversation into our future write-ups and into future developments, not only of future symposiums, but of the work we do at the Chicago Council writ large. And now, to further describe the theme of today's event, please join me in welcoming to the stage Catherine Jensen, Senior Manager of Corporate Responsibility for AbbVie. Catherine.
Thank you, Ivo, and I'm delighted to see all of you here this morning. For the past 3 years, the Chicago Council on Global Affairs has been contributing to International Women's Day discussions, specifically looking at global women's health. AbbVie is proud to be a sponsor for the 2nd year in a row. 2015 marks the end of the Millennium Development Goals, or MDGs. As you may know, the 8 MDGs were created in 2000 by the UN to focus international attention on solutions to poverty, hunger, and disease. And progress has been made. The maternal mortality ratio dropped by 45% between 1990 and 2013. New HIV infections in adults declined by 44% between 2001 and 2012. Many have contributed to the progress through individual efforts and partnerships. We are proud of the AbbVie Foundation's partnership with Direct Relief to provide rapid HIV tests to pregnant women. We've donated more than 26 million tests to date. The tests identify the mother's HIV status and, if positive, refer her to treatment and help prevent transmission of the virus from mother to child. This partnership has prevented HIV transmission to 225,000 infants over the past 14 years. Healthy women lead to healthy families and strong, resilient societies. However, there is more that we can all do in every corner of the world. And that is why the theme of today's Global Health Symposium is Rewriting the Goals. As we enter the post-MDG era, discussions are focusing on the creation of new sustainable development goals prior to the UN's Special Summit on Sustainable Development in September. The aim is to focus on the areas where we can have the greatest impact globally. In your packets today is a listing of what we might expect to see in September at the UN Summit. Not surprisingly, women's health is connected to many of the proposed goals. The theme for today's symposium is designed to encourage everyone to reflect not only on what has worked, but more importantly, what is next. This is where you come in. As you engage with the speakers and attendees here today, we want to hear what goals you think are most important to global women's health. Please share your thoughts and join the conversation with us on social media. You'll find hashtags listed throughout your booklet, and we encourage you to use them to make our conversation a trending topic. And even more importantly, please continue the conversation when you leave here today. I look forward to vibrant discussions both here in the room and online. Thank you, and now it's my pleasure to welcome our breakfast keynote panel and its moderator, the Chicago Council's Lisa Moon.
To kick off today's events, and let me be the first to extend my appreciation to you for showing up so early when it is 7 degrees here in Chicago. So that in itself is a feat. The first panel today is going to explore the important role that food can play in promoting nutrition and health. You know, as many of you know, I mean, for today, food is in many ways the most abundant and affordable as it has been at any other time in history. Hungry, which means they don't have access to enough calories. As many as 2 billion people are deficient in micronutrients like vitamin A and iron. But there are also 1.9 billion people that are overweight or obese. And these people are at risk for diet-related chronic diseases like heart disease, diabetes, and some forms of cancers. And if you can believe it, chronic diseases are actually now the leading cause of death globally. You know, malnutrition, I think, has often been viewed as a social issue, but it really, at its heart, is an economic one, and it really deserves more attention from countries and from businesses. You know, adults that were undernourished as children earn 20% less than those that weren't. By 2030, it is expected that the value of the productivity that is lost due to chronic diseases, many of them diet-related, will total $35 trillion. And these productivity losses really translate into economic losses. Countries in Africa and Asia lose, on average, 11% of their gross national product annually because of malnutrition. And the cost of treating chronic diseases is equivalent to almost 10% of most countries' GDP, and the US is certainly not omitted from those statistics. So why did we kick off a symposium in honor of International Women's Day with a discussion on nutrition? Well, because women, as Catherine really mentioned, are the game changers on the nutrition front. Women are the nutritional gatekeepers in their households. They are mothers, and their health before, during pregnancy, and while breastfeeding in many ways determines the health of their children. In many parts of the world, women are the ones that go to the markets, and they're also the ones that prepare the food for their families. But I think one thing that I often didn't think about before I started working on food and agriculture issues is that women make up almost half of the world's food producers. Right now, and this is kind of the focus of the Chicago Council's project, is really on empowering farmers, especially those living in Africa, Asia, and Latin America, to increase their productivity. And right now, between the US and European contributions, there's $8 billion annually flowing to that cause. I think that certainly that should be increased, but we should be thinking about how those funds can be supporting women farmers to be cultivating nutrient-rich foods. In 6 weeks, the Chicago Council plans to release a study. It's called Healthy Food for a Healthy World, and we're going to be looking at how all players in the food system can be supporting nutrition. And we're already having a discussion of these topics on our blog, Global Food for Thought, which hopefully you can check out. But this morning, we have a real chance to talk with two experts that are on the front lines of these issues. Kate Marr is the executive director of the Greater Chicago Food Depository. Kate, I was really shocked to learn that 1 in 6 Cook County residents depends on the Greater Chicago Food Depository for food each year. Kate has also led many successful initiatives at the depository, including meal production program to serve children and seniors that was named the 2008 Community Kitchen Program of the Year by Feeding America. Roger Thoreau is a senior fellow at the Chicago Council, having joined us in 2010 after a 30-year career with the Wall Street Journal. Roger has authored 2 books on the role of food and agriculture in fighting hunger in Africa, and he is now penning his 3rd, which is focusing on the importance of nutrition in the 1,000-day window between pregnancy and a child's 2nd birthday. And he's documenting the journeys of women and their children in 4 regions of the world: India, Uganda, Guatemala, and here on the south side of Chicago. Very regrettably, Lawrence Haddad from the International Food Policy Research Institute is stuck on the East Coast, so he was not able to come, but he sends his regrets. So with that, let's go ahead and kick off with you, Roger. When you decided to write a book on nutrition, why did you focus on the 1,000-day window?
Yeah, thank you, Lisa. Thanks for everybody who's come, particularly in these frigid weather. I've recently relocated to Washington, so that would usually be maybe a place of refuge from the cold, but not in recent days. But I escaped you before early in the week, before Lawrence, so that he got stuck there. And yeah, great to be on a panel with Kate. We've worked together a lot when I was still a reporter at the Wall Street Journal, and a great admirer of her work in the Greater Chicago Food Depository and all they do on this front. The reason I really wanted to concentrate on nutrition and on the 1,000 days window, because from all my prior reporting at the Wall Street Journal and for the first 2 books that I've done while at the Chicago Council, I could really see from and particularly the women that I was talking to and the women farmers in the book, The Last Hunger Season, the critical nature of nutrition, particularly early in life, and discovering that nutrition is certainly the cornerstone of human development. That then begins during a mom's pregnancy and then in the first 2 years of a child's life, when there's so much rapid development of both physically and in the cognitive development. And it's in that period, and as Lawrence documents in the Global Nutrition Report, it's in that period of this 1,000-day window when stunting begins. Both physical stunting, cognitive stunting, and in a lot of cases with a lot of children, stunting on both fronts. And so it's a shocking statistic, I think, and a sad reality of the world today, and shame on us that here we are 15 years in the 21st century, that 1 in every 4 children in the world, not just in the developing world, but in the world overall, are stunted, physically, cognitively, mentally, or both. And that happens in the 1,000 days window is really critical. And you can see the utter necessity of good nutrition in that time, because during the pregnancy, so much of it's basically through pregnancy and then the first at least 6 months or even more months of the child's life, really dependent for nourishment on the mother. The things that are happening, the development of the child in the womb, the relationship to food, kind of what's happening genetically in the child at that stage, so predicated on good nutrition. And then certainly as the child develops and begins with complementary feeding and eating solid foods, really, really critical. And then it was also, so as my time as a Wall Street Journal reporter and kind of realizing the importance of the economics of development issues, and finding the numbers and the economics that you were talking about, and again, as Lawrence lays out in the report, it's the impact of stunting really impacts all of us. So a stunted child somewhere in Africa or Asia is actually a stunted child here, because, and you feel the impacts here, because it's like throwing a pebble in a pond, and you see the ripple effect of it. And so as you were saying, the impact of a stunted child begins on the individual, the lower education that they'll have. And when you think about it, what stunting basically is, it's sentencing that child to a life of underachievement and underperformance. They're going to go to school less. Their lifetime earnings will be less. Their productivity is less. The impact then ripples beyond the individual to the family. It's one less full wage earner in the family. And the hopes and expectations on that child that, they'll be perhaps one that, advances with a job beyond the farm, brings more income into the family. So that's gone by the wayside. The impact on the entire community, because if there's one stunted child, there's going to be more in the community for the whole nation. And the statistics you were saying on the impact on the equivalent loss of GDP in Ethiopia, and these countries are starting to calculate these impacts themselves. Maybe the equivalent of 16% of GDP is lost through the cost of stunting, and then the additional medical cost as things go on, the loss of productivity. The regional aspects that you said, the 11% equivalent of GDP that's lost in Asia, South Asia and Sub-Saharan Africa. And then the global cost that people are also beginning to tally, that it might also be kind of the equivalent of 2 or 3% of global GDP is impacted through malnutrition and stunting. I think the World Bank, the Food and Agriculture Organization say in dollar totals it might be as high as $3.5 trillion a year. The loss of international trade, the loss of productivity and economic growth. And what I think is kind of perhaps the greatest cost is almost unmeasurable, and it's the opportunity cost. What might a stunted child have contributed to the benefit of all of us and to the benefit of the world were they not stunted? And when you think of the possibilities, it's just staggering. And so these costs add up, and so that's why I really wanted to concentrate on the 1,000 days, that critical period and window of human development, and then particularly on nutrition. And it's all aspects, it's nutrition. It's the access to the micronutrients and the access to the food, but all the elements that support nutrition, the wash use, the water, the sanitation, the hygiene, the environment that they're in. So the efforts to get the nutritions into the bodies of the moms and the kids, and that they stay there. It's not through bad water that through diarrhea and other infections and diseases, it then leaves the body, or through this parasitic overload, then that it's the parasites and the worms that are then consuming the micronutrients that are meant for the host body. So it's kind of a fascinating look through the through kind of all the elements in the 1,000 days that basically end up resulting in this horrible stunting situation.
Thanks so much, Roger. Kate, I know that you're serving, is it more than 500,000 meals to hungry Chicagoans every year? I don't know if that's right. Hopefully it is.
It's more than that, actually.
Okay. Well, could you tell us a little bit about the nutritional needs of some of the families that you work with?
Sure, and let me just first of all start by saying what a privilege it is to be a part of this conversation. As a Chicagoan who's a member of the council, I'm so excited to see the council reflecting on the role that hunger and nutrition play in building a healthy world. I'm also so excited to be with Roger. As we've joked, we've had the opportunity to be on the road before together, and it's great to be back on our road show. So I want to just take a moment and talk a little bit about who we serve at the Greater Chicago Food Depository. Because I think particularly, this is the hard part of going after Roger. I think when we think about hunger, even when we don't have Roger talking knowledgeably and with such passion about the issue globally, we have a tendency to think about a problem that is a world away from where we are right now. And this is one of the challenges we face in Chicago and in other parts of the country, is that for so many Americans, we still think of hunger as a problem in Africa or Asia. And so we sort of get, at the food depository, often a perplexed stare as people look at us and say, you know, who could possibly be hungry in Chicago? And the challenge, as Lisa noted, is that many, many people in this community struggle with basic access to nutritious food on a daily basis. At the food depository, we are serving annually 812,000 men, women, and children. It's 1 in 6 of our neighbors who woke up this morning just like we did, heard the weather reports just like we did, had all of the same challenges, but had the additional challenge of not knowing where or when they were going to be able to get the food that they needed to eat today. Now, the reasons people struggle with hunger in Cook County are different than many of the reasons that people struggle around the world. When we think of hunger in other parts of the world, it's war, it's weather, it's geography. In America and in Chicago, it's poverty. So when we look at the people we are serving, it's not terribly surprising that 1 in 6 of our neighbors needs to turn to a food pantry or soup kitchen to get a meal, because there are more than 1 million people just in Cook County who live at or below the poverty line. And many of you know this, but I think it bears a little bit of clarification what that means to be in poverty, because there is a very clear technical definition. If you are in a family of 4 and you have less than $23,000 of income, you are in poverty. $23,000 for a family of 4. Can you imagine? I think most of us know what it costs to live in a city like Chicago, so we can easily understand how if you are making $25,000, and you're not a poverty statistic, if you're making $35,000, it is still a daily challenge to put food on your table. And families and individuals, mothers, fathers, are making tough decisions every day and tough trade-offs, right? Do you pay the light bill or do you buy groceries? Do you buy the new pair of shoes or the winter coat? Do you pay for a bus pass or do you buy groceries? And increasingly, those are the tough choices that we see families making. And one of the unfortunate consequences is that sometimes the quality of the food that people choose also suffers. And so when you have a limited amount of resources, sometimes the choice that you make is to buy the cheapest calorie you can find. And often, in many of the neighborhoods that we serve all across Cook County, the most readily available and least expensive calorie comes in the form of soda, comes in the form of snack foods. It's not necessarily the fresh fruits and vegetables, whole grains, and lean proteins that we know are the building blocks of a healthy diet, which is why we are doing such a brisk business at the Greater Chicago Food Depository. I wish it was only 500,000 meals. This year, we're on track to distribute close to 70 million pounds of food. And we are proud of the fact that 35% of that are fresh fruits and vegetables, but we're also sobered by the fact that the need is continuing despite signs that the economy is getting better at an all-time record pace.
Thank you, Kate. Roger, Kate really talked about some of the the challenges related to poverty here in Chicago and the unique circumstances that hungry families in America face. You know, as you have documented the situations of these families in Chicago, but also in Guatemala and India and Uganda, what are some of the commonalities and also differences that you've seen about those family situations?
Yeah, that's a great question, Lisa. And it's kind of a fascinating part and a revelation to myself as I do the reporting. I just wanted to kind of echo and second what Kate was saying, and the lamentable statistics and the great work you do, and kind of the unfortunate work that you do. That's one of the reasons why I really wanted to also in the book follow some women in the United States and in Chicago, particularly on that point that it is not a problem that is just over there somewhere that we see in the news or some unfortunate place in the world. It's also a major issue here, and what happens then, particularly in the 1,000 days and the critical nature for the development of our society. And Eva was talking about the NATO summit, I think in 2012 that was here. That same day, there was another summit in Chicago, and that was the Scaling Up Nutrition Summit. And I was moderating some of the panels there, and Mayor Emanuel, when he spoke at kind of the lunchtime there, he said, I've just come from the NATO summit, which I think was in McCormick Place, right, on the more southerly side of the city. And there we were talking about issues of great security for the fate of the world and things. He says, now I'm here at the Chicago Historical Museum and on the north side, and here we're talking about an issue that I consider, and everybody in the room obviously would consider, to be of also equal importance on global stability. And then he talked about the meaning of the 1,000 days and nutrition for Chicago, and was then obviously talking about, you know, the food desert issue. And he was saying, look, he considers where there's a food desert, it's also opportunity deserts. It's a security desert. It's an education desert. It's a job desert. It's a health desert. And so that all these things are bound together. And so that's one of the things that I'm finding in Chicago. And for the commonalities, kind of no matter where I am, and talking to the women and the moms and the families, the basic education and nutritional education about the type of foods that should be eaten and consumed, and looking at a balanced diet and the micronutrients and how important that is, and the unfortunately the cheap food that's affordable is oftentimes the kind of the worst food for your body. It's providing calories, not the vital nutrients. So it's been fascinating then to kind of sit under a tree in Uganda or on a veranda of a house in India or in a little community center in Guatemala, and then come here and some of the home visits and the doula program with Ounce of Prevention or the Metropolitan Family Services, to hear basically the same dietary and nutritional information that I'm hearing in all those other places. The cooking classes that I observe elsewhere, how to cook, how to get the best mixture of nutrients and how to prepare meals. I see those same cooking classes here. And so as I'm going through this, it's like, wow, particularly reinforcing always the point that Kate's making, that these are the same issues that are here. Poverty, underlying issue here and elsewhere in the world where I'm at. And Kelly, we were together in Uganda at one stage, and then seeing other projects with concern. And that was the essence there, the lack of access to basic services, health services, sanitation. And then the other commonality that one also finds here is that, so you have this information, and then there becomes this burden of knowledge. Okay, here's what I'm supposed to do and what I should do as a mom during pregnancy and then raising my child, and then it's the information for the mothers-in-law and the other caregivers and the dads as well. But then there's this gap between, okay, I get it, I understand all that, and they're taking notes a lot of times. And I talk to them at home, and yeah, I'm kind of making the cooking and following the plan and the instructions that I have. But then there's a gap then between the accessibility, the access to the food, and then the affordability of the food. And the same as it is in Chicago, it's the same elsewhere. And at one stage, everybody in every country, as they were talking about this, they were telling the instructors who were kind of going through this, these are the fruits you should eat, and the vegetables and type of things. And at one stage, everybody as I went around to the countries, were all saying, do you know what the price of apples are? I get it. We're supposed to eat things like apples. Do you know how expensive they are? Or in India, all of a sudden, lentils, kind of a staple of the dal and other things. Do you know how expensive lentils have become? And so the whole food system then becomes part of that. And you know, how can we make these things more, the good foods more available and accessible? The other thing, a commonality, is the really important nature then of behavior change. And that's also really hard to do. So the information's there and you can do the teaching, but then to make that change in behavior, whether it is in you know, issues of care for the child or at the time of delivery issues and in the early hours after birth, and to really kind of breaking away from, say, some traditional, cultural, social, religious, spiritual reasons for the way that they do things or have been doing them, to then adopting new methods and practices, and particularly on food. And I think it was the anthropologist Margaret Mead who said it's easier for a man to change his religion than to change their diet and their habits of eating. And so this is kind of, there's the commonalities, but then there's the challenges. And then one of the great differences then is the difference in infrastructure. But of all the moms that I'm following, it's just the moms in Chicago who are able to make regular neonatal visits, who may have 3, 4, 5 ultrasounds during the period of the pregnancy, sometimes more if there's any difficulties. In all the other countries, none of the moms are having ultrasounds. There was one of the moms that when it came time for birth, the mom didn't know, the doctors didn't know that the first baby comes out, and then it was like, oh, you're having twins. And they had offered her, she was having some difficulty before, it was maybe her third pregnancy. The other 2 were okay. So if you well, this one will also be fine. But the doctor's saying, look, if we want to do an ultrasound, it'll cost the equivalent of $7. She says, no, I don't have that. I'm assuming hopefully it'll be okay. And then, you know, it got to that point. I'm going to be sparse on some of the details, so I don't want to kind of ruin the drama of the narrative that I'm trying to build in the book. You'll come across, I've already read that, or I've already heard that. So we don't want that to happen. But so it's kind of those infrastructure issues and just access to, you know, basic health services. So that's why all this is kind of supporting nutrition. And I think we find in nutrition, certainly what we're finding, I guess, in the council report that'll be coming out that Lisa mentioned, that nutrition is this bedrock issue for all development issues. If you want education initiatives to succeed, nutrition, and particularly in the 1,000 days, is really important, again, for the cognitive development of the children. Health initiatives are really important, you know, because of that. The whole issue of chronic disease, and one's looking at this what is being called this double burden, that in addition to, in say a country like India, that has 40-45% malnutrition and stunting of children, there's this paradox that stunted children, when they become adults, have a higher propensity for overweight and obesity. So all these stunted children and malnourished children in India, as they grow up, they're becoming overweight and obese. And so the obesity numbers and overweight numbers, as Lawrence chronicles in the Global Nutrition Report, are rapidly escalating in places like India and China, and their huge populations. Those are, and so then the economic benefits and the costs and the healthcare implications of that for those economies then become tremendous. And those are economies that we're depending here in the United States to kind of move the global economy. So you can see how that weighs down everything. And so, and then one is also finding then kind of this double burden also in the United States, that in the same body, the person will be both malnourished and obese, and obesity then obviously one form of malnutrition.
Thank you, Roger. That really helps, I think, give us a picture of what malnutrition and what challenges I think people are facing commonly around the world. Roger mentioned several organizations. I know that you're partnering with Ounce of Prevention here in Chicago, Concern overseas and some areas, and others. You know, Kate, delivering 70 million pounds of food I'm just shocked by that number, and it's not an easy feat. Can you just talk a little bit about the partnerships that you've forged at the Greater Chicago Food Depository that allows you to reach that number of people?
Sure. So this is, thank you for asking that question, because this is not an effort that's only undertaken by the Greater Chicago Food Depository. First, for those of you in the room who aren't from Chicago, I have great news for you, which is wherever you live, you are in a community served by a food bank. There is an amazing national network called Feeding America of more than 200 food banks that cover every county in the United States. And I think it's important to note, even though I'm focused on Chicago and I can talk a lot about hunger in our community and to a certain extent in other large urban centers, it is not only an urban issue. I have the privilege of chairing the Illinois Commission to End Hunger, and I can tell you from my work on that commission, hunger is alive and strong in every one of Illinois' 102 counties, and some of the challenges in rural communities and suburban communities are particularly acute. But we work in partnership here in Cook County with the most amazing grassroots, scrappy network of partners that are based in the communities in which people are struggling. We have 650 different programs that every day are distributing food. They range from well-known, strong, vibrant human service organizations that provide a host of other services, Salvation Army, Catholic Charities, Heartland, a lot of organizations that are really administering a variety of basic needs. Food is one of them. To the other end of the spectrum, a lot of food pantries operating in basements, in churches, in communities that are struggling. On a note, this isn't the focus of today, but just an important note, not only are the majority of people accessing services from the Food Depository women, the majority of people responding on the front lines are also women. And when we think about these volunteer organizations on the front line, right now, as we're sitting here, there are food pantries all across Chicago, all across Cook County, where volunteers are handing out bags of food and fresh produce to families turning to them. The face of that volunteer, more often than not, is a woman. And so it is this incredible network. We're, of course, fortunate to partner with people on the food side of things. I always joke particularly when I'm in a room with food industry folks, we try to leave no stone unturned. So we will ruthlessly pursue food anywhere we can get it. But we also have a variety of other community organizations that we partner with. I see the Chicago Foundation for Women sitting there in front of me, because as I said, this is not just a supply chain issue. This is a poverty issue. And at the Food Depository, we have this dual set of responsibilities. On the one hand, our job every day is to ensure that the highest quality, nutritious food flows out to everybody in our community who needs it. And that's a Herculean task, particularly when you have very cold weather, and diesel trucks do not like very cold weather. I'll tell you that from firsthand knowledge. But even as we are focusing on the supply chain and being an efficient organization that is focused on the delivery of perishable food, fresh produce, and other quality nutritious food, we're also an organization that is engaging in advocacy and thinking about how do we shorten the lines at all of the food pantries in Chicago, in Cook County, in Illinois, and across this country. And so we have a number of critical partnerships on that front as well. Organizations that are focused specifically on poverty issues, on economic development, as well as government partnerships. And those are an important part of the response to hunger.
Thank you, Kate. You know, Roger, I want to pose a similar question to you. You touched on kind of these organizations that you're working with to document the journeys of these women and children. Can you just talk a little bit maybe and give one or two examples of some of the most innovative approaches to helping promote nutrition in the 1,000-day window that you've seen on the ground?
Yes, absolutely. And so that's one of the things that I also want to highlight in the book are kind of innovations that are going on the ground, people that are kind of pushing the frontiers of this. And in each of the countries, that was, the women that I'm following, the families, are all involved in some kind of nutrition behavior change program along the way, because as a reporter, my initial challenge was kind of how am I going to find pregnant women in places, and I just couldn't go into a place and kind of, you know, kind of who's pregnant here. I would have been slapped a lot and probably, you know, deported from all the places, and wouldn't stand a chance of getting a visa back to most of the countries.
So glad you didn't do that, Roger.
Huh?
So.
Yes. So it's been great help with people on the ground. In Uganda, the women that I'm following, their families, they're farmers, as are many of the women in sub-Saharan Africa. And they're part of a program called Harvest Plus, which is, there's a lot of fortification efforts that are going on, a fortification of the foods with the valuable micronutrients. And there you see partnerships with a lot of companies. Say Unilever, DSM, the big Dutch vitamin company, organizations like Micronutrient Initiative, they're in Canada, right, Carly? And then Vitamin Angels. And then on the biofortification front, instead of adding nutrients to food that's already been produced, so corn or wheat or rice that's being milled, and then you kind of add the nutrients on top of that, or the fortifications that we have here that you find in a lot of our foods. Biofortification is you get the plants to do the work themselves and the crops, and so they're more micronutrient-rich crops, and they're basically through conventional breeding, highlighting the minerals that are already in the crops. And so these women in northern Uganda are growing, just in the last couple of years, it's been introduced to them, orange flesh sweet potatoes, so rich in beta-carotene, which the body then turns into vitamin A, which is a critical mineral and vitamin for early development of children, and they're growing high iron beans. So beans already have an iron content in them, and so through breeding you just highlight and you increase the amount of and in that part of Uganda and pretty much throughout Africa and the developing world, anemia and iron deficiency is critical. I think in Uganda it's maybe 85% of children under 5 and maybe 50% of women and pregnant women are iron deficient and anemic. And all the women can kind of complain about that and their feelings when they're pregnant. And just the anecdotal stories of kind of how they're feeling with this pregnancy that I'm following them with as perhaps compared to earlier pregnancies, the development of the child that has been born. They're talking about biofortified babies and biofortified generation children that are born after the introduction of the orange flesh sweet potatoes and the high iron beans. And they'll say the development markers that a mom notices are faster or more rapid in development of this child. It's like, what do you explain that? How do you explain that? It's like, kind of the only thing in our lives that have changed are these new crops that we're growing. And then an organization like World Vision is on the ground working with them on kind of the education, the behavioral change matters. In India, an organization, Community Empowerment Lab, that is really big on behavior change, changing things like, it's common in the villages where I'm following women that say the initial breast milk and the colostrum was just routinely and traditionally discarded. It was part of the cleansing process. It was seen as unclean. It's like, no, the colostrum in particular has all these valuable antibodies that are very valuable for the baby and then set them up for a healthier life. And so they're big in behavior change and kind of really pushing the envelope on that. In Guatemala, a local clinic that's doing a lot of work on the environmental aspects and the cleanliness and to knock down the parasitic load. And then obviously the organizations here that I mentioned that are doing a lot of work with the moms during the pregnancy and the home visitations then after the child is born. So there's a lot of innovative work going out there that I think really leads to quite a bit of optimism and hope that we can get on top of this problem. And the whole thing with hunger and nutrition is these are not problems that we have to tolerate. And that we shouldn't accept. These are things that we know how to solve, and we don't have to have them in our societies.
Thank you, Roger. Before we go to the audience for questions, Kate, I wanted to ask you one last question as well. You mentioned that 35% of the food that you deliver is produce. But I'm sure, I know you and I have discussed what a challenge it is to get that fresh produce. In your ideal world, if there were, either a partnership or an innovation that you would like to see happen in the state of Illinois, specifically around fruit and vegetable delivery to food banks, what would it be?
So I may not have enough time to describe my ideal world, but a couple of fronts. I think we do increasingly need to look at how we can, through innovative partnerships with growers, make sure that there's fresh produce available in abundance for all people. And we're really excited to be having a conversation with members of the council on how we can make that a reality. I think there's also an important role that healthcare plays. This intersection between hunger and health is critical. When we look at the people we serve, 60% of the people who get food from the Greater Chicago Food Depository have high blood pressure. 40% have diabetes. So if you are hungry, you are likely not healthy. And this is a very preventable reality if we can access or help people access fresh produce. I also want to just, if I can take a moment, talk a little bit about solutions. I was in Washington earlier this week, and we brought 34 people with us. Many of the folks in our small but mighty delegation were volunteers at food pantries and clients themselves. And they were all women. There were 3 stories that got shared with members of Congress that I think are really relevant to our conversation today. The first, one of our co-travelers, partners, was a woman named Jackie, who is now a social worker at one of the partners that helps us distribute food. And Jackie shared her story as a single mother living in Chicago Housing Authority housing, and the role that the food stamp program, or SNAP program, played in making it possible for her to put food on the plates of her children. And I can share with you, there was not a dry-eyed in the room when she shared a very personal set of experiences and the role that that somewhat misunderstood program plays in ensuring that families have access to food. The second woman who shared a story was a woman named Maria, who talked about when she became the guardian for her younger siblings, the role that food pantries played in making sure that she was able to fill the plates of her younger siblings. And again, a very moving and raw testimony that she shared. The third story was a woman named Tammy, who talked about when her father lost his job and what it meant for their family, and how all of a sudden she and her brother had to have that school breakfast and school lunch, because those were the only 2 meals that they were going to get that day. And she talked about how her father would go and find shopping carts and return them to the grocery store to get a dime. And if he collected enough dimes, he could pay for the part of the reduced price breakfast and lunch that parents were required to pay. That particular advocate is Tammy Duckworth, who is now a member of Congress. And I think it's important for people to understand that we have this incredible safety net of programs, school breakfast and lunch, the SNAP program, the WIC program, that are on the front lines, but they are also being questioned and attacked. The safety net is stretched so thin, We have got to have strong private programs that can provide fresh produce, like Food Depository and the other food banks in this country. But we also have to make sure that the federal nutrition programs that provide the first line of defense for women and children in this country continue to be strong and provide support when families need them most.
Hey, Lisa, I was just going to point out that's also a really interesting thing that so in these other countries that I'm reporting, they're in the process of seeing what kind of safety nets can they build, because that's one of the differences. So here there is this safety net, and in other places non-existent or extremely thin and horribly underfunded. And so looking at both political commitment and things that can be done, and it's just a contrast that in those places you find them wanting to build up a program, and here these programs that are here then are under threat, and people that want to diminish them. And so I find that as kind of a weird and disturbing paradox, in a sense, that we've been the leader in that, and now others are kind of wanting to emulate what we do on that front, and then there are forces here that are saying, no, we don't need that.
Thank you for bringing that up. I think it was a really great way to end this part of the discussion. We have about 15 minutes for questions from the audience. Maybe I could suggest that we take 3 first, and then we can respond to those and then go for a second round. So if you have a question, just please raise your hand. How about the gentleman right down the line here? Please state your name and organization before sharing your
Idris
question. Thank
Odwell
you.
with the Homeland Security Newswire. And this question is for you, Kate, as well as Roger. How do you plan for a world where your organization and your work, the demand for those services decreases over time? Because the whole point of aid is to get to a point where fewer people need aid. So is that something you consider in your strategy going forward?
Absolutely. So we talk a lot internally about putting ourselves out of business. I'm an optimist at heart. I know that we still have a lot of work in front of us with 812,000 people relying on the Food Depository. But that's what we're striving towards. And part of that is about making sure we lift our collective voices to make sure that the network of government programs that are designed to protect families and individuals are strong. This is, as Roger said, an amazing set of programs that are being emulated, and yet we are in a process right now of trying to dismantle these programs. I will share with you some of the conversations in Washington about, people literally asking, do we need a women, infant, children nutrition program? We do. And the future of our country is at risk if we do not have strong programs for women and infants and children, if we don't have a vibrant school breakfast program and school lunch program. And so the first effort is really making sure that those programs are strong, that they get to the people that they need to get to, and that we can make the case for the impact that they will have. But we also have to talk about other ways of making a vibrant community, whether it's making sure that we have strong schools or jobs for individuals so that they can support their own families.
Okay, great. What about the gentleman over there?
Hi, my name is Kevin, and I'm here with Project Cure. And actually, question: what are you guys' opinions on urban farming initiatives in food deserts, and how that can impact or make a difference?
Okay, great. Thanks, Kevin. We're going to go ahead and take 2 more questions, and then we'll respond to all 3. Does anyone else? How about the woman over here, please? Thank you.
Morning, my name is Elizabeth Mangami. I'm with DePaul University. My question is for Roger. Hi. I was really excited to hear you speak about the first 1,000 days, micronutrient uptakes and stunting around development. But then the question came to me, which I hope you can address, is what about CSBs? I work sometimes in Zimbabwe, that's where I'm from, and we have a huge issue around trying to get international NGOs and funders like USAID to look at investing in local growers so that we're not depending on CSB, because when you talk about micronutrient uptake with CSBs, there's really very little chance. So I was just wondering if you could address what we could do as advocates to try and get the discussion to move around supporting local growers for fortified foods.
Great question. One more. Yes, Alan, please.
Alan Matthew, when the U.S. government supports, does price supports, for example, like for sugar, that the price of sugar is guaranteed at a higher price here in the U.S. than a world price, and you walk into a grocery store and you see, 2 liters of Coke or Pepsi for 98 cents, it seems to me you've got two battles going on here. You're going to Congress for one battle, and you've got Congress supporting the thing that's actually hurting you, which is the sugar.
Great point. Roger, maybe do you want to respond first to any of those questions, and then Kate?
Those are all great questions. To the first question, just to kind of echo some of the things that Kate had said, and particularly your point on, that's the whole point of development aid, that people then become self-sufficient. And I think, kind of what one's seen of some of the programs and what the current administration is doing, and things that actually, were being written about by the council in 2008 and 2009, and kind of this renewal of American leadership in ending hunger, say through agriculture development, and shifting kind of the pendulum, which had swung far in the direction of food aid and emergency food aid, short-term solutions, and basically shifting that to longer-term solutions of agriculture development. The bulk of our food aid goes to feed hungry farmers. And so there's kind of an absurdity of that, and a bizarreness and an obscenity of that oxymoron of hungry farmers, that why not help create the conditions for these farmers to be as productive as possible, so that they are able to grow enough food to feed their own families, and enough nutritious food to nourish their families as well. And that then the goal of aid, to kind of, then we don't, those, if they're self-sufficient in growing their own food and adding to their communities, hooray. And so that's should be indeed the point of it. The urban farming initiatives, I think are great, and that's one of the things that I'm looking at. I was down, I think on 61st Street by the University of Chicago with the Experiment Station, and kind of the work that they're doing on that. Have seen some at the old Cabrini Green area, and I think that's great, kind of in creating more volume of the fresh fruits and vegetables, and in kind of the information, the cooking classes and things that they also have around it, I think is a valuable contributor to that. But I think one caveat that one has to have, and it also then kind of instills in people's minds kind of the whole relationship to food and where it comes from. And so that's also really great. But I was on a panel a couple of weeks ago in Washington, and Tom Colicchio, one of the prominent chefs, who's also really a proponent of this movement, he said, look, that's all great, but it's not going to be able to solve this bigger problem that Kate's addressing and is dealing with. There are structural issues, there are poverty issues that need to also be addressed. But on many of these other levels, I think they're really good programs. And in the question from DePaul on, absolutely, you need to invest in local producers, in local farmers. And then, so it's not just a matter of the production of the raw materials, but then it's then transforming them into the necessary products. And so the more that's done locally, and local suppliers then providing the ingredients and the crops to those producers, but that's kind of this virtuous cycle that needs to go on, and I think is really important. So investments either by kind of international aid or by a lot of the industry, and be they multinationals or whether they're kind of the larger corporations kind of in the countries, I think is really important. Because again, it's those producers on the ground, the local producers, they're also in local needs. And so what I'm seeing with some of the fortification efforts you can then tailor the fortification to the supply, kind of the micronutrients that are particularly deficient in those countries and in those areas of the country. So I think that's really important. And on Alan's point, there's a lot of times these countervailing forces in the politics and you know, the various programs. But I think that really addresses basically kind of all the programs and policies that look at a bigger solution to the structure of the food system in the United States, and that each piece of legislation is, yeah, it's an individual thing, but they're all kind of bound together.
Thanks, Kate. Roger, Kate.
Do I have a minute just to respond?
Oh, no, absolutely. You have about 2 minutes.
I won't take it all, but on this question of urban agriculture, which I think is a really important one, it's an exciting movement, and I think a lot of us at a community-based level are really just overjoyed to see people thinking about how they can bring an initiative into a community that brings people together to grow and to create a really vibrant set of opportunities. And I think it's incredibly exciting. From a food production standpoint, it's a minimal amount of food. However, we live in an incredible agricultural state. And I think we need to challenge ourselves to think about how can Illinois grow more food for people in need in our own state. Lisa referred to a project that we're working on with a set of policy recommendations that we hope to present to the governor and the General Assembly. We see a lot of opportunity, frankly, to encourage and help farmers, whether it's going back into their fields and capturing the seconds, fresh produce that would be plowed under because they simply don't have the resources. And we're not even talking about paying market rate. There are a lot of farmers who, if they could just have enough to cover a little bit of the cost of a worker who stays on an extra week, or a little bit of the cost for the transportation of getting that food to a food hub, they want to feed people. Farmers do not want to plow food under, but we have to pilot and try new ways of connecting farmers in our state with people who need food.
Kate, that's a great point. You know, last week, the council, one of our colleagues, Louise Iverson, did a piece on just food waste and how 1/3 of all food is wasted in the world. And in America, a lot of produce is wasted, up to 50%. It's not because it's bad, but simply because we love our produce to look pretty. We don't like it to be bumped and bruised. And so if, just like these programs that Kate is mentioning, if we would have an incentive for farmers to be able to sell that produce that is not exactly perfect, whether it be to provide it to the food banks or even to provide it at retailers and people can purchase it at a reduced rate, that would be great.
You know, Lisa, that's also kind of in terms of commonalities from before. All these other countries, and particularly India, there's a lot of innovation going on that looking, here our food wastage comes in food that's prepared for consumption and we end up throwing away. Or then the weird looking or the ugly fruits and vegetables that people don't want. In a lot of parts of the world, the food doesn't even get off the farm or to the markets for all sorts of distribution and infrastructure reasons. The storage systems are crummy and goes bad. So a lot of fascinating innovation on refrigeration, refrigerated trucks, how you move that whole system quicker, that maybe kind of through an Uber type system, the farmers call a transport company, say, I'm harvesting today, I'm picking my bananas or my fruit or my vegetables, and by 4 o'clock I'll be done. You know, can we have a truck there or some refrigerated cab that comes by or something and they take it somewhere? So all this kind of, you know, innovative thinking, a lot being done by students at universities and even in high schools, you know, that are really looking at this, at all these issues.
Terrific. Ladies and gentlemen, regrettably, that's all the time we have. Please join me in thanking our panelists, Roger and Kate. If you have further questions, you can catch Roger and Kate here. I'm sure you can also connect with them on Twitter. So please join me too in welcoming to the stage Neve King, our Vice President for Programs.
Thank you. Thanks, Roger. Thanks, Kate. Thanks, Lisa. Good morning, everyone. I'm Neve King with the Chicago Council on Global Affairs. Thanks to you all for coming. And I have to say, it's so exciting to see so much of the next generation out in this audience. We're really focused in the council on engaging the next generation in Chicago and downstate, because I know we've got people from Illinois College. So Thanks to you all for coming out. I wanted to explain, you've probably noticed some changes to the schedule, although it's cold here. We are not the culprit. It was that big storm back east, so we've had to move around some of the events today. Instead of going to the breakout sessions after this great panel, we're going to host the Global Mental Health panel in here for everyone. Then afterwards, you'll all go downstairs to the second floor, and then we'll have our 2 breakout panels down there. But now I'm delighted to welcome to the stage a leader from Chicago who's working hard on issues related to women and children every day to explain an exciting initiative taking place here in Chicago that's being called the Burnham Plan for Women and Girls. Please welcome to the stage Kay Sujata, the president of the Chicago Foundation for Women. Thank you.
Good morning. So after the conversation you just heard, I know you have an exciting and important day ahead of you. You've just heard about the importance of food security and nutrition, the basic necessity for good health. Access to health and health information is integral to women's economic empowerment and is intimately connected to becoming free from violence. And it is as important whether you're here in Austin, in the Austin neighborhood in Chicago, or whether you're in Sierra Leone. Since our founding, Chicago Foundation for Women has worked to remove barriers and provide safe, just, and healthy lives for women in the region. We've worked with community organizations for 30 years, and I can provide some telling examples, stories we hear every day. Women returning from the front lines of war often experience homelessness and unemployment. Many have experienced trauma, sexual trauma, let alone physical trauma. So both physical and mental health are compromised. You're going to hear on the mental health panel right after this. The mortality rates of women diagnosed with breast cancer in Chicago are worse than those for women in Nigeria. These numbers are twice as bad if you're in neighborhoods like Washington Park, West Garfield Park, or North Lawndale. 3 in 10 American girls will get pregnant at least once before the age of 20. Not just that, a quarter of teen moms have a second child within 24 months of their first baby. At Robeson High School in Chicago's South Side, the main reasons girls are dropping out of high school is because they become pregnant. This has parallels to child marriage in Nicaragua or Nepal. But it's not all doom and gloom. There have been measurable improvements, even in 2 of the areas that I just mentioned. When we understand the problem and properly focus our attention on and resources, there are truly positive changes that can happen. In 2011, the teen birth rate in the United States fell to the lowest level recorded in nearly 70 years of tracking teen childbearing. In Illinois, the number of births to teens has dropped by 40% thanks to the work of grantees like EverThrive Illinois here in Chicago. And about that subsequent pregnancy, Options for Youth in Chicago has found that direct intervention not only leads to higher graduation rates and delays second pregnancy for 97% of the teens, but also better parental involvement, including that of fathers. Research now shows that with regular screening, breast cancer disparities drop among Black women, particularly in the early stages. The Chicago Metropolitan Breast Cancer Task Force has found a 35% decrease in mortality rates among Black women, thanks to specific and dedicated attention paid to addressing these disparities. While my experience is mainly in metropolitan Chicago, we can learn much from the rest of the world. And some solutions here might be of interest to those working in other countries. However, for far too long, we have worked in silos, to your point earlier, Alan. Even though we know that these issues are disconnected, We are siloed in women's economic advancement, which is often separated from health outcomes and the impact of violence against women. The Millennium Development Goals of promoting gender equity and empowering women is not just an abstraction. We firmly believe that women's health and freedom from violence are intertwined with economic well-being and essential for growing and sustaining vibrant communities, not only locally, but also globally. And we need to reach these goals with some urgency. We have to translate these development goals for ourselves. So Chicago Foundation for Women is doing something about this. Neve mentioned the Burnham Plan. So we're leading a citywide effort to identify the most pressing issues facing women and girls that will produce specific outcomes to remove barriers and increase opportunity. With this renewed urgency, we must think differently about solutions. We must mobilize individual, collective, and institutional action and catalyze systemic change. CFW is collaborating with people and organizations to create a plan that mobilizes a network of leaders in our city to define a shared set of solutions. It is ambitious and it is vital. It is the civic plan, our call to action for elevating women and girls. It will identify opportunities for programmatic, philanthropic, and legislative solutions. This is a plan that focuses on key measurable improvement in the lives of women and girls. This is a plan that will keep our leaders accountable. This is a plan that we can all get behind. As you head into your next sessions, we hope that all of you will consider goals and specific steps for how we can work together to elevate women and girls here or elsewhere. You can host a conversation or provide your input online on our website. We can make this easy for you and send you a toolkit if you'd like. I hope that you will consider bringing your collective power to improve lives. I hope that you will consider creating a world we want, a world we deserve. Thank you.
Good morning, ladies and gentlemen. My name is Kelly McShane, and I am a member of the steering committee of the Council's Women and Global Development Forum. Thank you for joining us and for participating in this timely discussion of global mental health, a topic that is integral to the discussion of health, but one that unfortunately does not always get the attention that it merits. Today's mental health care system must be equipped to deal with a range of mental health issues, some related to brain development, others manageable by basic prescriptions, and others caused by gender-based violence and post-traumatic stress. Not only is there stigma attached to those suffering from these sometimes debilitating conditions, but due to a lack of understanding, there is often not enough investment in resources or research. Scarcity of resources is especially prominent when we consider that 14% of global disease is attributed to mental, neurological, or substance disorders. And 75% of those affected come from low-income countries where they don't have access to the proper treatments. Today, we are pleased to have with us two panelists who will discuss the importance of investing in global mental health and how their organizations target this issue. You have a full copy of their bios on your chairs and in your program, but let me briefly highlight a few points of their careers. Our first panelist is Scott Portman. He is the Director of Special Projects and Senior Technical Advisor at Heartland Alliance International. At Heartland, he is in charge of a variety of projects related to human rights, including work with refugees, the LGBTQ community, and survivors of trafficking. Our next panelist is Carly Silver. She is the Vice President of Targeted Challenges at Grand Challenges Canada, where she leads the Saving Lives at Birth, Saving Brains, and Global Mental Health programs. Previously, she was a postdoctoral fellow at the Sandra Rotman Center in Toronto, researching malarial infections in pregnant women. Lynn Reich, who has spent her career working on women's health issues, will lead the first conversation on stage, and then, as before, open the floor to your questions. Please join me in welcoming our panel.
Good morning. Having had the opportunity to learn a little about Carly and Scott's work, I feel very privileged to participate on this panel with them. Their work in the field of global health is wide-ranging and yet so basic. This morning, we will hear some compelling reasons why mental health needs to be elevated and made a priority, and where it is happening. I'm going to direct the first question to Carly. What is the current problem regarding mental health, and why should we care about it?
Yeah, well, I think our introducer there just did a great job to say essentially there is no health without mental health. I mean, that's the tagline that the WHO uses to really pitch this issue. If you have mental health issues, as many people in the world do, I'm sure if I kind of polled this room, that people would either have personal stories or family member stories, or at least know a colleague or something who suffers from a mental health condition. And many of those in areas of the world, such as the US or Canada, can be managed very productively, and people are very productive members of society despite living with a mental health condition. That's the reality that we live in. At the same time, where we don't have access to the care and treatment that is needed to manage these conditions, as about 90% of the world doesn't, then we have some serious issues to deal with, and this can lead to other complications when we're talking about wanting to achieve our health goals in the MDGs or otherwise. Someone with a mental health condition is more likely to contract HIV, is more likely to have a non-communicable disease like the chronic diseases we were hearing about, obesity and such, later on in life. And I think, and I know we'll get into this later, but the idea of the widespread stigmatization around the world, here as well as elsewhere, that prevents us from talking about this has really limited our progress generally in health and in development.
Scott, can you describe some of the causal factors for mental health concerns? Some of the reasons around the world why we are seeing so many problems?
Well, first off, there's a biological basis to many mental health disorders, or many mental disorders, and so there's a uniform sort of background level of prevalence for many diseases around the world. But this is exacerbated by a lot of other issues. So, for example, the worldwide prevalence of depression is about 4%, but depression is more prevalent among women in much of the world, and you can't really separate that from lack of economic opportunity, and you can't separate that from violence. And of course, prevalence for all sorts of other disorders really varies a lot according to the circumstances of that the population faces and the challenges. So for example, PTSD obviously is extremely variable, post-traumatic stress disorder, from one country and one situation to another. And not just post-traumatic stress disorder, but a whole host of other problems associated with traumatic stress. So the issues that lead to, you can't really separate out gender from issues of mental health and mental illness. And also, of course, you can't really separate out issues of poverty or lack of opportunity either. So these things are all interrelated. And the burden, persons with mental illnesses, with actual clinical mental illnesses, their circumstances are made worse by war and strife and conflict. And so there's, and even in the United States too, at Heartland Alliance International and Heartland Alliance generally, we sometimes talk about trauma-informed mental health, which is a really important concept because, most homeless persons with severe mental illness in the United States experience trauma sometimes on a daily basis and have a history of having experienced violence And the effects of trauma, of traumatic stress, magnify underlying mental illnesses and substance disorders. Let me also just say that WHO says among the top 10 causes of years lost, of productive years lost, major depression and substance use disorders are in the top 10. So, not only are our mental health problems have a huge human burden on individuals, but they've got a huge economic burden as well.
I think I'd like to take just a moment to step back and have you maybe summarize a little bit what each of your organizations does so that people can put that into perspective a little bit as you talk further this morning. Carly?
Sure, thank you. So I'm lucky to work with Grand Challenges Canada, and it's an organization funded by the Government of Canada, and our whole mandate is to fund bold ideas with big impact in global health. By bold ideas, we mean science, social, and business innovation, and by big impact, we're really looking on saving and improving lives in low-resource settings around the world. And one of our programs, as was mentioned before, is on global mental health, and what we're really looking for there are innovations that can increase the access to care and increase the effectiveness of treatments. And layered onto that is this idea of widespread stigmatization, that even when there is services that exist, it's very difficult for some people to actually take advantage of them. And I might just, while I have the floor, I might just say, tell you one story that I think is one of the most moving stories that describes this idea of a lack of hope and stigmatization that I've heard. It's from one of our innovators in sub-Saharan Africa, and talking about how during one of his previous projects, he had been polling a certain village and going door to door and asking the parents, how many children do you have in your house? And at this one house, when he asked the question, there was this little hesitation that he kind of picked up on, and the person said, I have 3 children. And he said, and do you have any others? And they said, yes, 1. And he said, can I see that one? And so he was led to the back kind of corner where, in a very, very dark area, essentially the child was contained in this space. And really, it was something that could be managed at the same time without the parents knowing that there was any sort of thing that they can do. And with some of the cultural kind of stories that go around explaining what would be happening to that child, it became very difficult for them. And so they really had to have this dual balance of almost ignoring that child at the same time, having to protect that child. And so it's a very tricky situation for a family, and that's the kind of thing we're looking to mitigate with the innovations that we support.
Scott, I read the mission of the Heartland Alliance International is to protect the rights and well-being of those who are marginalized. Can you expand on that a little more?
Sure, marginalized and most vulnerable. I'm also very fortunate to work for Heartland Alliance, and specifically Heartland Alliance International. Heartland Alliance has a long history of working with mental health programs here in Chicago, largely with very vulnerable and marginalized populations. So Heartland Alliance does a lot of work with homeless mentally ill, through, among others, their Pathways to Home program that allows persons with severe mental illness to transition from the streets to stable housing. But also, here in Chicago, we have the Marjorie Kovler Center for the Treatment of Survivors of Torture, which has provided mental health services for the last 3 decades to victims of torture from around the world who have come to seek refuge in Chicago. And more recently, Heartland Alliance has, over the past decade or so, Heartland Alliance International has begun to work in the area of mental health abroad. So a lot of our work focuses on training of paraprofessionals and professionals to work particularly on depression and post-traumatic stress disorder with survivors of human rights abuses, often torture. We're currently working in Colombia, in Iraq, the Great Lakes region of Africa are the areas where most of our mental health programming is, although we work in 12 different countries.
Scott, how do we know when a program is successful? How do you determine whether it's having the desired impact? And are there cultural factors to consider in your evaluation? How does a Western perspective sometimes contrast with your measures of success?
Well, the issue of culture and mental health and programs to address mental health is a really complex one. Person's sense of meaning about their lives, about their relationships with their family and their community, people's understanding of what's going on with them are informed, of course, rooted deeply in both their culture and their religion and in their communities. And so people's explanations for mental illness or for other things that aren't precisely mental illness, such as post-traumatic stress disorder, are very, very much culturally informed and rooted in culture. At the same time, we're all human. The differences between us biologically are minimal around the world. And schizophrenia everywhere. There's, the physical consequences, some of the consequences of PTSD occur throughout all cultures and all places. Major depression occurs about 4% of the population worldwide. It's greater in areas of trauma and stress and conflict, but there's an underlying baseline for these disorders. And one of the tricks to mental health programming is trying to understand definitions of well-being and functioning in each society in which one is working, and also trying to correlate that with Western conceptions, or maybe I should say scientific conceptions of the etiology and origins of mental illnesses and mental disorders. So that's kind of a tricky thing to do. We can perhaps talk a bit more about that. But in terms of measuring efficacy, that's also a little bit difficult in mental health programs. Many times people never have anybody empathetic who wants to even listen to what's going on with them, or doesn't want to stigmatize them, or wants to offer some sort of assistance, or even treat them humanely, particularly persons with severe mental illness, but also persons with depression or PTSD who may have been rejected by their families. You can have a situation where there's two siblings, both of whom experience torture, and one of whom suffers from major depression or PTSD and the other doesn't. And the reaction of the community and the family may be to stigmatize the one that has negative effects from their experiences. So it's, there's, what I was trying to get to before I sort of digressed there was that even the initiation of mental health services creates an increase in people's reported, alleviation of symptoms. There's a placebo effect to a lot of what happens. And there's also a very real effect just simply listening and just simply talking to somebody. But there's also real tangible effects that come from things like cognitive behavioral therapy, that comes from things like medication, that comes from other sorts of interventions that one might do that go above and beyond whatever the basic improvement is once somebody is able to engage in services. And it's kind of tricky to tease those two things out. So in the area of PTSD treatment, certain evidence-based treatments like cognitive behavioral therapy, which can be modified to fit the cultural context, do alleviate symptoms above and beyond the sort of background alleviation of symptoms that happens once somebody starts engaging in mental health services.
Thank you, Scott. Carly, perhaps you'd like to share some of your thoughts on that. And also, at the Global Mental Health Initiative, what is it that you're trying to achieve? What are the goals that you have in mind?
Yeah, absolutely. So, I think Scott really tackled that context thing well, and just to add that I think this is an interesting element that we're learning a lot about because of our global mental health program. We've essentially funded about 63 projects around the world in the last 3-4 years. Sadly, this shows you how how sparse the funding is in this area. But in that short period of time, and with about 30 million Canadian dollars, so it's not even American dollars, that we've managed to become one of the leading funders in global mental health in the world. So this is a green field that really needs other people to come in and pay this the due attention. But what we're trying to do with that collection of innovations and that community of innovators is to really have some of these conversations about how much contextualization needs to be happening. How do we actually measure success as we go forward? What are the evidence-based practices, and where are they working, and for whom? And so the kinds of things that we've been able to tease apart are kind of just starting to come to fruition, given the timeline that we're looking at. And remember, innovation is something that takes a little while before we see the true impacts. At the same time, even over this last 3 years, and even with these early interventions, early innovations, that some of which are operating at very small scales, Collectively, we've been reaching about 45,000 people into mental health services that wouldn't have otherwise before. And so we're starting to make strides against this. And I think some of the more kind of bright spots for me to show that we are on the right track. I'll give you two examples. One is actually outside of our program, but just shows you kind of the full spectrum of what's starting to happen in this field, is this website organization called It Gets Brighter. And this is an area where people are able to share either their personal stories or stories about their loved ones, supporting their loved ones, and how essentially what the impact of mental health is on their lives, but also to reassure other people that it can get brighter and there is hope out there, because that's a big part of this whole puzzle. We hear lots about the huge burden of the problem, and I think where we need to start changing the conversation is giving tangible things that are happening and are working out there to make sure that we actually have some ways forward. Another example I'll give you, and one I'm particularly excited about, is a larger project that we've just started funding. This is an organization called Basic Needs. It operates in about a dozen different organizations or countries around the world, and it has a primary focus on mental illness. But the interesting thing about how it operates is it doesn't just look at the person living with mental illness as a health challenge that needs to be solved, but also really trying to tackle the social and economic issues of that person as well, to make sure that there's essentially just a well person coming out of this issue. And they've managed to reach 125,000 people over the last few years. And what we're excited about helping them with in the next little while is how do they actually start stretching beyond the bounds of their organization with this model to other franchisees, other organizations that can pick this up and keep spreading it further and further, with the idea that we can really accelerate the progress in this.
Thank you, Carly. Both of you have worked with diverse populations. Why are women and children particularly important to focus on? And what do you consider the key issues?
Well,
either one.
Well, first off, women and children are particularly important to focus on. Well, first, let me talk about children. Programs for children can't exist that are not in context of the family. So mental health programs for children are really programs for families, and that means programs for women as much, because the reality is worldwide, most caregivers are women. So mental health programs need to be integrated into maternal child health care worldwide, and I'm sure Carly will have quite a lot to say about that. I think the other issue also is that as I mentioned earlier, the burden of disease on women from major depression and PTSD is higher because of all the other vulnerabilities that women face: economic deprivation and violence within the home. And also, cultural issues that prevent women's mobility and prevent women's access are greater. And I'll divert for a second and just talk about perhaps an example. Most of us have heard recently about the kidnapping of women by the so-called Islamic State in the Middle East, and that these women are then sold for purposes of sexual exploitation, and a number of them escape. The stigma associated with sexual assault for women in the Middle East is extremely high, and these women, when they're capable of escaping and when they can get back home again, face restrictions on their movement from their own families. They face stigma. They feel shame. They've internalized a lot of the beliefs about women's sexuality and about blame. Many of the women have internalized this, and so they feel a great deal of shame. And of course, on top of this is just that this was an unbelievably, unimaginably traumatic experience, and so most of them are severely depressed, and most of them have consequences of traumatic stress, some of them full-blown PTSD, or at least acute trauma. So all of these issues result in disproportionate effects on women and disproportionate vulnerabilities to women and lack of access. And so that really needs to be addressed not only on an individual basis, but on a community basis. One of the things we're hoping to do is to be working with leaders of the different ethnic and religious minority communities in Iraq, with the leadership on messaging on how to communicate with members of their own communities to reduce the stigma, and then also how to improve access to the women themselves as they escape. On On gender, let me just say one other thing. Worldwide, about 1 million people commit suicide every year. And as we know, in the United States, LGBTQ people are at greater risk of committing suicide because of cultural factors, because of abandonment by their families, because of systemic discrimination, which is getting better, but still it remains the case that suicide among LGBTQ people, both in the United States and worldwide, is quite a bit higher. And so when we talk about gender, I just wanted to just remind folks that this also includes sexual orientation and gender identity, and that this is something that needs to be integrated into relief and development programs and health programs throughout the world. UNHCR, the United Nations High Commissioner for Refugees, has worked on revised gender mainstreaming guidelines that does this in a refugee context, and I think a lot of kudos to them for really taking the lead on that.
Thank you, Scott. Carly?
Yeah, so I want to answer your question that builds on what Roger was talking about, that first 1,000 days, and really draw us back to that when we're talking about children with respect to mental health. What we see is a huge window of opportunity in the earliest years of a child's life. And this really has to do, again, with that brain development that Roger was talking about. And so while nutrition would give you the energy, give a child the energy needed to form all the connections that are happening in the brain at a very rapid pace in those early years of life, there's other things that also happen when there's interactions with the primary caregiver and with the child's surroundings that help strengthen or pare down those connections that are being made. And these brain connections in that early years of life really forms a foundation for the child's ability to be healthy and well and learn and be a productive and peaceful member of society later on in life. It's often thought about, the analogy that's used is kind of a tennis match, this serve and return. So a positive form of interaction that a child interacts or has in those early years is with their caregiver, and really the communication that happens long before there's actually any verbal language that's happening, but it's those sounds, it's the eye contact, it's things like that really can help strengthen and give the child this knowledge that there is someone in the world that is really comforting and caring for them. On the flip side of that, when we have children who experience neglect or abuse, or have themselves parents who are suffering from mental illnesses that prevents them from having that strong bond with the child, that we can actually set up these vicious kind of 2-generational cycles. So at the same time, I completely agree with what Scott was saying before, this idea that as we're thinking about women's and children's health from one standpoint, as we're thinking of mental health from another standpoint, I really think that this is all part of the same puzzle we're going after here. If we're wanting children to be growing up healthy and thriving, we actually have to really pay attention to how healthy and thriving their parents are, and the support systems that have been put in place in order to let those mums, primarily mums, but more and more evidence showing how important dads are on the picture as well, to really be nurturing the next generation as a very healthy path. And just to give you a bit of context about our Saving Brains program, that's essentially what we're looking at there, is how do we have innovations that can help bring together these health and nutrition, the early stimulation, and the child protection elements that are so critical for a child's early years as their brain is forming, that really can set up a lot of things so that it can happen later on. There is lots of evidence to show you can intervene later on. It is harder and it is more expensive. And so when we're talking in some of these areas of the world where resources are incredibly constrained, getting it right the first time is probably a good bet, and we should attempt to do that in the first instance.
With the Saving Brains initiative, I believe there are various ways that you are measuring results from that program. Could you share those with us?
Yeah, absolutely. I mean, this is one of the ways our whole organization is really focused on making sure we can say what the impact is of the innovations that we're funding. Not a simple game when you're talking about innovation. Often it's kind of seen as this blue sky thing, and yeah, in a little while we'll get to results. We try to link them up as soon as we can, and with Saving Brains, all the ideas of the context and the culture and things like that makes this a very tricky conversation worldwide. At the same time, if we want things like child development and mental health to exist on platforms such as the Sustainable Development Goals, we need to move towards a conversation where there are elements that we are seeing as measurable and trackable so that we can actually have a layer of accountability that's going on. In Saving Brains, we have identified a set of core metrics that all of the innovations that we fund are tracking against. This has everything to do from physical health and a child's height for age, as well as things like how well they're interacting with their caregiver, the language, executive functioning, which is essentially can you have the kind of higher order of cognitive functionings that can let you manage lots of different thoughts and actions and desires in life to actually kind of stay on task and stuff. And this is those early things. Some of you might have heard of the marshmallow test. This is an example of an executive functioning. Have a 4-year-old sit in front of a marshmallow and tell them, don't eat it for 10 minutes, and if you don't, I will give you 2. And YouTube it because it's actually a great example of how difficult this is for a 4-year-old. But they've been able to link that in the United States. Kids who do well on that at 4 years of age do very well in life. And so this is kind of one of the early indicators that we have that potentially an executive functioning skill set is an important one to predict long-term health and wellness.
Thank you. What are the opportunities to seize upon in the area of mental health? How can audience members become part of the solution? How can institutions help?
Well, as was mentioned earlier, the Saving Brains initiative by the Canadian government is one of the largest funded mental health programs internationally, and Canada and Holland, or the Netherlands, are 2 of the main funders of mental health programs. And the United States kind of isn't there. It integrates funding into different programs, but not at quite the same level and not at quite the same specificity as many of the European Union countries and as Canada. And so one place to start is, the United States development agencies really should have a specific focus on mental health and really do more to integrate mental health into primary healthcare systems. They do some of that, but not nearly enough. The other thing here domestically, the number one place for people to get mental health services in the United States is in jails and prisons. And it's much, much cheaper to treat people through assertive community treatment, to treat them in the community. It's cheaper than jailing people. And so, when people talk about cutting back, community counseling centers of Chicago, or when they talk about cutting back the budget in the state for taking care of mental health services and increasing the prison budget, I have to say that it just, even for a fiscal conservative, it makes no economic sense at all. I think the other thing is, for people here in Chicago, I mentioned earlier the Marjorie Kovler Center for the Treatment of Survivors of Torture. People who are interested in mental health issues and traumatic stress for people coming from abroad, for welcoming the asylum seekers and refugees in our own communities. Kovler Center welcomes volunteers and welcomes input from people in the community, and you can find out more about that afterwards. And then generally, we would like, of course, for all of you to follow our programming. I think I also wanted to just make a mention. The Crown Foundation has funded mental health programs in a number of different areas, and is one of the leading foundations in this regard. So that's probably also worth a mention.
Carly?
Yeah. So I could go a bunch of different ways with this, but I guess maybe where I'll head is three different things that I think a crowd like this probably could help push this whole agenda forward. The first being that there's a lot of mental health programs out there that are at early stages and are showing really promising results. And what is limiting them from going beyond that early stage and those limited results is the kind of ability to look at how this can actually be done sustainably and at scale. there's a whole engine in the business community that has this baked into what they do every single day. And insourcing some of the approaches to how we approach service delivery, how we approach HR, how we approach the ability to actually keep quality into systems is something that I think there's a lot of overlap. And so when I often speak about wanting investors to come into the global mental health arena, I will obviously take dollars as well, but I also think that even more important, and alongside those dollars, what would be very powerful is some of the expertise and networks that exist in other sectors to bring to the table. So that would be one. The second, I would say that looking at how we actually have more of conversations around mental health in everyday life. There's a great initiative in Canada that I'm aware of called the Bell Let's Talk initiative, and this is really the Bell Telecoms has a Global Mental Health Day where they incentivize people to talk to each other about mental health, or just simply talk to each other, because as we were saying, that idea of actually having someone listen to you and know that they're reaching out to you is one part of the puzzle in terms of improving mental health. And I did have a third one, but I can't quite remember it at the moment, so I'll leave you with those two.
Well, the timing is right, because I think it's time for us to open up the panel to audience questions. Let's give them a round of applause now, though. They were great.
Thank you, that was wonderful. We'd like to go out to the audience for questions. Just raise your arm and wait for the mic. Right here, please, at table 5. Thank you.
Hi, Priya Agrawal, Merck for Mothers. First of all, thank you so much. As you pointed out, advocacy is sorely needed in this space. And I completely agree you can't have health without mental health, but I don't think you can actually have safe, secure societies without mentally healthy societies, and we don't have to go far to see the problems with that, indicating the Tennessee news this morning. But I have a question about gender as we're here on International Women's Day. I lead a maternal health program. It's the low-hanging fruit, right? Integrate postpartum depression. You can't have a healthy child without a mentally healthy mother. But I do worry about shining the spotlight on women when it comes to advocacy for mental health. So hysteria was a word that came from hysterus, the womb. Many of these diseases are thought to be just crazy women. And in a way, women have coping structures because they do talk. So I'd love your thoughts on how much we should really be focusing on women and children, and perhaps we should be starting with the less marginalized populations, i.e. men, when it comes to mental health.
Yes. No, we'll just take one at a time. Thanks.
Fantastic question, Priya. And so I think I'll state my overall answer first, which is I do think that focusing on women is a smart move in this space, not at the expense of a broader population. But I think, as you pointed out, there's some areas where women are particularly prone to this issue, and the really strong multi-generational effect of that is something that I think is worth paying attention to. In some areas of the world, postpartum depression can hit rates up to 50%. And this is often when women don't have the ability to have those support networks, that they're very isolated. Often these are women who didn't have a lot of choice as to who they were marrying or when they were marrying, and that can happen very early. And so there's a general, it's really like linked with this disempowerment of women. And I think the ability to go in and I think it doesn't necessarily need to be a mental health intervention in a way. I think there's a lot of things that can be done under different names that is going to get to the same end. So the ability of even the women's groups around perinatal health are ones that actually can likely be improving mental health. And at the same time, the ability for women to know that there is another way to be conversing and acknowledging that what the situation that they're in is not an ideal one, and they have some power to problem solve around that, I think is a very important one.
Scott, did you want to comment on that?
Well, I would just say that as a practical necessity, one has to focus on women and children for all the same reasons that you just mentioned. But I would say in the context of post-conflict societies or conflict societies where we do most of our work, of course, everybody's affected. Everybody knows this, and everybody has a mother, so to speak, and everybody knows that this affects, women and men both. I can only offer an anecdote. In Colombia, we have a torture treatment program among the Afro-Colombians on the west coast of Colombia, where we train paraprofessionals. Most of the people who get services because they are the mothers of people who have been disappeared and killed. The men oftentimes don't make it back once they're caught, and it's the women, their mothers, that bear the burdens. And so many of the people that access services are middle-aged women. And there's not really, at least in Colombian society, there's not that much stigma to that. It's kind of expected. People understand what the war was, and they understand what happened. Everybody sees among their male relatives who are participating in various conflicts the consequences to them, and everybody expects that there'll be consequences to women. So I don't, it's odd. It's a great question, and I was thinking about this because I was thinking how odd it is that this issue of women's hysteria or women being weak somehow, or women not being strong enough to handle these burdens and therefore needing the mental health services. This all historically makes sense, but in practical reality, it doesn't seem to me like there's that much stigma, in fact, in the work that we do. There's the underlying cultural issues that women face, but the accessing mental health is not, it's not feminized in a negative way, I don't think, at least from my perspective. Could be wrong.
Thank you. Next question. Yes, please. The woman back there with the purple shirt. I think it's purple. Maybe it's black. Or maybe it's white and gold.
Hi, my name is Valerie Scarbuck. I do freelance communications and development work for nonprofits. I traveled to Uganda a few years back and learned that individuals with mental illness are sometimes seen as being demonized, or it's a voodoo sort of thing. So I'm just wondering, and I think it is so misunderstood just even in the United States with all the information that we have. So I'm just wondering, how well is it understood in different parts of the world, and what sorts of treatments are available, whether cognitive behavioral therapy or medications?
Yeah, that's a big question. I'll take a bit of it and then I'll pass it to you. So I think your idea of, or your question about how well it's understood is a really valid one. There are lots of places where it is seen as more of a demonization, or there's other cultural stories that have been built up around to explain what is being observed. That can change. We have a project in Haiti that is actually working with voodoo healers to essentially educate them and have them become part of a community-based treatment in mental health. So I would say that there are ways to tap into the position that some of the people who create and uphold those beliefs and kind of change them for or pivot them towards a more championing of a healthier outcome is one thing that I would say to that effect.
I could give about 1 million anecdotes on this because it's such an interesting topic, but I think one of the things that I might have mentioned earlier is that it's important when designing mental health programs and doing mental health programs not to contradict the beliefs and culture and to work within the culture and the context of the culture in which of your population. One very quick example, in another Iraqi example, women who are unable to have children in Iraq, in many Iraqi communities, go to Sufi saints' tombs and pray there for children. And lack of having, childlessness is a contributing factor to depression in any society where women are expected to have children and where they want them. And so I remember having a conversation with a doctor one time who we'd been training in a mental health program, and he said that he would tell them that they were idiots to do this, that there's no validity to this, that there's nothing that they can get out of this, that this is biology, so you got to buck up and get with the program, so to speak. And we kind of counteracted that because it causes no harm for women to do this, and it's part of the culture, and it's not contrary to providing mental health services to the population. There's other practices that may be dangerous, and that then becomes a little bit more complicated. I'll give one other anecdote right now. We're beginning a program to try to address suicide of young people in an indigenous community in Western Colombia. And in this community, there's a lot of clustering of suicides. You know, it's an indigenous community that really is kind of undergoing disintegration because of mining and because of violence and a bunch of other problems that are going on. And people are being, you know, there's a pattern where people see a spirit in their dreams that tells them to kill themselves. And so now the way to address this that we haven't figured out, but that we're just starting to kind of think about, is how does one subtly change those messages? Not tell people that there aren't spirits, not telling them that their dreams are meaningless, not telling them that, you know, whatever they're trying to hold on to their culture has no value, but how to internally change the messaging on suicide and the aftermath to suicide, so that to de-incentivize it in a way. And so I don't see these two things. Maybe I'm getting a little bit off your question, but I don't see these two things as necessarily being in conflict. You really have to take an anthropological perspective and really combine the two to the extent that you're able.
Thank you.
Sorry, I was just going to say on the question of what works, I would say the WHO has a very good resource set called the MH Gap series that is a great place to start for any sort of evidence-based practices around the world.
Thank you. Next question. Yeah, right over there, please. The lady with the glasses.
Thank you so much for both of you for being here today. So I'm a second-year graduate student at UFC, and I'm also a therapist at the Kovler Center. I think quite a bit about, because I'm working with survivors of torture this year quite intensely, I think quite a bit about the social determinants of mental health and environmental determinants, and also historical trauma. Locally and domestic, you know, here in Chicago locally and also abroad. So my question is, in both of your work, how do you take cultural competence and it's kind of in the same vein of what you guys just answered, but how do you take into account how depression and mental health is manifested so differently in different cultures into account when you work abroad? And also, how do you take historical accounts and trauma of how, you know, the presence of Americans or Canadians, I don't know, abroad, you know, play into the fact of your work?
Scott, do you want to take that one first, please?
Sure, I'll start with that one. First, thanks for volunteering at Kovler Center. We encourage people to do that, and that's a very good thing. Yeah, I mean, I think one of the issues when we're working outside the United States, we're not really using Western-trained psychologists except in a training capacity. So the service providers are not people that have got, you know, degrees in clinical psychology from here. Rather, we're training paraprofessionals in kind of a give and take. We're training them on evidence-based practices and together with them, helping match those practices to their culture. So in most of the world, it's going to be a long time before there's enough psychiatrists and master's degree clinical psychologists or even bachelor's degree social workers or master's degree social workers. It's a practical necessity in most of the low resource world to train paraprofessionals. And those paraprofessionals come from the community. They should be recruited among people that have some status in their society and some credibility in their society, people that are taken, you know, seriously within their society and trusted. So the recruitment process is important, but then also the adaptation of these various interventions has to take place as kind of a give and take. The other thing that we do a lot in several programs is that we kind of map symptoms. We map definitions of well-being and we map symptoms, and we sort of compare that to the DSM or to other diagnostic criteria. And we try to develop, and in some cases we've actually come up with measures of well-being based on the society's own criteria for well-being as a measure of efficacy, along with other psychometric measures that measure depression and anxiety sort of universally. So I think that in a practical way outside the United States, it ends up being kind of a hybrid. But it's a really good question and a really important issue, and it deserves a lot more research.
And maybe I'll just really touch on the historical element of it, and I'll actually flag an organization that's in Alberta in Canada called the Norlean Foundation, and they've done a lot of work focused on this link of what those two, the saving brains to mental health kind of path that I was sketching, how those early years and experiences in that early years can actually be kind of embedded in your body and really shape a lot of how you interact with the world later on. And part of their messaging is, especially when we're talking about in Canada the phenomenon of kids who grew up in residential schools, so taken from their families, put in a different culture, a very traumatic experience, and Canada is very much struggling with this in the Aboriginal communities. Actually, taking that lesson of the brain science and that story that it has to do with what happened in the early years, and this can help flip the frame of people feeling like it's actually not their lack of willpower or things like that. There's actually things that they have to go back to and accept that happened to them and figure out ways to work within that bounds that I think is a very powerful thing that is starting to happen more and more in different environments. So there's obviously a symptom reduction element to mental health that can happen, but I think there is a powerful thing that if we start pulling in this full life spectrum approach that we can really start getting to some of the roots of these multi-generational effects that can happen.
Thank you. One more question. That gentleman right there, please, next to Jen.
My name is Kevin, and I'm here with Project Cure. And I was curious what your guys' opinions are on the war on drugs and how it criminalizes as victims of substance abuse opposed to treating them as patients in our system.
Scott, do you want to go first on that?
If you'd like.
No, go ahead.
Well, I mean, our take on these things as an organization is that we embrace a harm reduction model. We see substance disorders, substance use disorders as disorders, and we try to
I'll tell you who I met the other day. I met this
My name is Kitty Lansing, and as a steering committee member of the Council's Women and Global Development Forum, I'm delighted to be here today to introduce you to this very important discussion. Our panel features 3 experts who will discuss the benefits of investing in women's reproductive health, a topic that touches on both the health of women and economic, 2 critical aspects of goal setting for the future. In 2013, the World Health Organization reported that 800 women died every day from complications related to pregnancy or childbirth, and almost all of these deaths could have been prevented. An investment into the health of these women offered not only individual benefits, but substantial social and economic ones as well. Women with access to reproductive health services have fewer children, have healthier children, or healthier mothers, and contribute to defray the ever-rising costs of health care. The question remains how to encourage the global community from through NGOs to fully embrace this concept. Our guest today will delve deep into this topic and more thoroughly explore why investing in women's reproductive health is a critical and responsible goal. You have a full copy of their bios on your chairs, but let me briefly highlight a few points of their careers. Priya Agrawal is the Executive Director of Merck for Mothers. She previously served as Director of Research and Development for the Women and Health Initiative at the Harvard School of Public Health. Our next panelist is Jenny Klugman, who is a Senior Advisor at the World Bank and a Fellow at the Harvard Kennedy School's Women in Public Policy program. Jenny recently published a major World Bank report on the topic of investing in women's reproductive health. Our final panelist is Purnima Mane. Purnima is Pathfinders International's President and CEO, where she oversees projects supporting sexual and reproductive health programs in more than 20 developing countries. And 30 years of leadership experience, including positions at UNAIDS and the World Health Organization. Purnima will lead the conversation on stage and then open the floor to your questions. Please join me in welcoming our panelists.
Good morning, everybody, and thank you for being here. It's so wonderful to see the room full with so much excitement to hear from the range of panelists that you have here. This morning, as you know, we are going to be talking about smart economics, women's investing in women's reproductive health. And our panel is going to explore why and how investing in women's reproductive health can have a substantial impact on economic outcomes and development. And I'm going to use my moderator's prerogative to ask the other panelists 1 or 2 questions. If we run over time, I'm going to only ask them 1 and leave it to you because we want interaction and we want you to be part of this conversation. So I will save time at the end for our presentations, and Megan will lead the Q&A. I think Kitty's already introduced you and already told you how many years I've been in this business. And over the years of working in development and health, the one belief that I have firmly held is that development cannot happen without focusing on women. Not only are they 50% of the world's population, which is kind of the obvious reason, but often they are the most neglected and marginalized when it comes to efforts in relation to development. They are the most harnessed for a range of socioeconomic benefits to their families and societies, much less to themselves, and always an afterthought when it comes to reaping the benefits of development. So it's about time we focus on women for women's sake. Far too long, we've not done enough for women to the extent we should, and where we have, we've seen the results. And you're going to hear some results today. Not surprising, countries that are investing in women also rank high in GDP, overall economic development, and women's position in society and economic development are intrinsically related. That's really the premise of this session. Jenny is going to be presenting quite a lot of evidence that shows why investing in women and reproductive health and rights enables women to continue and to contribute to economic development and allows them to lead a safer, healthier, and more fulfilling life, both for themselves and for their loved ones, and of course, for their countries, their communities, their nations. So let's just look at the situation. Can we go to slide 2? It doesn't matter if we can't get there, but I'll keep speaking. Globally, there are 600 million girls between the ages of 10 and 24. Many of these girls, as you heard in the morning, get married early, as they do in the US, much more in the developing world. They get sexually active early. They drop out of school. And all of this denies them their social and financial contribution to their families, as well as their countries, and their own fulfillment in terms of what they could achieve if they stayed in school and not dropped out. It denies childhood. Many people don't forget that childhood is also a right, but in many developing countries, it isn't. Many have children when they're themselves children, often causing preventable morbidity and mortality in pregnancy-related complications, depriving a whole generation of the possibility of having an educated and informed mother. This sort of seems hardly fair or even rational when we do have the resources, when we do have the technology, we have the know-how to change this pattern. One of the projects that Pathfinder works on is called Prachar, and it's a project in India, and our effort was to change this pattern in a corner of India which was considered sort of a little bit, if I may use the word, hopeless. Nothing's ever going to change, the poorest, and where the average age at marriage for girls was 14 when we started working there. The project ultimately reached more than 1,200 villages and more than 1.3 million people in the state of Bihar. But it reached them with what was again referred to this morning. I love the linkages between the sessions. Behavior change. Comprehensive behavior change and sexual and reproductive health programming. Working with boys, working with girls, working with parents, working with teachers, working with local leaders, and healthcare providers, all aimed at the same goals: delaying the age at marriage and promoting healthy living and spacing of pregnancies. Next slide, please. Over 4 years, this resulted, you see those results there, so I don't have to, I hope you can see them because I can't, in an increase in the use of contraception to delay the first pregnancy, an increase in the use of contraception to space pregnancies, because that's very important in terms of preventing maternal death and morbidity, and also increase the number of girls that stayed in school. All of this made it possible, therefore, for the Bihar state itself to get very excited about it, and today the program is being considered as something that the government wants to take to scale all over, not just the districts in which we work. Next slide, please. Empowered women who can make decisions about when they marry, when they have children, and how to protect themselves from sexually transmitted infections like HIV are always women who are empowered to contribute in more ways than one to their families and societies. The example of Mozambique is something which we always cite. We have a program here that we run which is a female condom program. The idea was to increase access to female condom, teach them how to use female condoms at the community level by organizing support groups for women. Most of the women, of course, were of reproductive age. About 5,000 young women joined these groups, and they discussed a range of topics related to sexual and reproductive health, including negotiate with their partners, about using a condom. And the results for us were truly electrifying, because it not only did it build their capacity to speak up, but it meant that they created their own businesses. They were able to speak up in their communities, and those women who participated were able to ask for loans, for example, look for support on other issues, and fulfill their own dreams to the extent that they could. That's really the power of what you can do when you bring a group of women together to talk through some of the issues that they are dealing with. And finally, investment, next slide please, investment in sexual and reproductive health does pay. We have so much evidence, and I'm tired of people saying, what's the point? It's taken so many years, nothing's happened. A lot has happened. We often don't see that because we are so busy looking at the negative side, and there's a lot of the negative side too. For example, you see worldwide, contraceptive prevalence has gone up. And unmet need for family planning, that is when somebody has a desire to practice family planning but actually is not practicing it for a variety of reasons, has actually decreased, and the data show it very clearly. Next slide, please. Globally, maternal deaths have dropped 45% between 1990 and 2013. And antiretroviral coverage among pregnant women living with HIV has gone up. It's reached 62% in 2012. And the number of newly infected children infected with HIV was lower in 2009. And all of these instances, mind you, the countries where the situation has improved are countries where development as a whole has markedly improved. That's the important point I do want to emphasize. We've also got the well-documented cost implications of not investing in women's health. For example, in Ghana and Benin, the complications from delivery can be as high as 1/3 of a household's annual expenditure. And that's a phenomenal amount. We heard about nutrition this morning, and you can imagine what that means to a family when they have to spend for delivery in this fashion. And we also know what the benefits are in terms of investing in women. Every dollar, next slide please, every dollar spent on providing reproductive health services to women can generate $120 in annual benefits. Investments in reproduction, in a very prestigious report called Adding GDP Growth, up to 9 times the investments made. Now, we have all these data. I just want you to pause and think about it, because I'm going to ask some questions to our panelists based on some of this data. So I'm going to state the obvious at the end. It is both the right and the smart thing to do to provide sexual and reproductive health services to women, because it is good for women and they deserve it. And it is good for economic development as well. And for this to happen, both the public and the private sector to be engaged to make a difference, and that's why this panel is also delighted to have Priya from Merck for Mothers talk about a groundbreaking venture that Merck has launched in order to make the difference, and she's going to talk you through it. So let me turn over to Jenny, who's going to give you an overview why investing in sexual and reproductive health is smart economics, and delve into what we already know about the connection between sexual and reproductive health and development more broadly. So over to Jenny.
Thanks, Panima, and thanks very much for inviting me here today. It's great to have the opportunity to participate in this important event. What I'm going to do is to recognize, of course, the centrality of reproductive health to gender equality, but also to underline that there are major constraints which are holding back progress, and to be thinking about the structural drivers which are limiting gains in this area, but as well to highlight promising areas where we know that change is happening and progress has been made. But as Panima asked me, noted, part of my brief was actually to begin with the costs of ill health. And just one point I wanted to put on the page before we go any further is that whilst there has been this overall progress, and I think the global numbers are impressive, the kind of almost 50% reduction in maternal mortality, the increases in contraceptive access and so on, when we look across countries around the world, and these are the regional rates of maternal mortality with country outliers, you can see that in all of the regions there are countries which are way above the regional average in terms of maternal mortality. And in Africa in particular, there are about a dozen countries or more which are above the regional average there of about 550. So whilst there has been progress, these major gaps still do persist. Indeed, this gap between maternal mortality in developing countries as a whole and in the developed countries is about 15 times. And that's been described as the largest disparity existing in public health. Actually, that statement was made some 20 odd years ago, but it remains the case today. So why is this a problem? Just a slight update. I worked at the World Bank for, I guess, more than 2 decades. I'm no longer there right now. But one of the things working as World Bank economists is that we had to try and persuade ministers of finance, governments, and indeed kind of fellow staff why it's important, why we should be investing in reproductive health. Clearly it's a human right, but what difference does it make for the economies? And there's important kind of lines of investigation here. I'm not going to go through all of the evidence, but just to put these into the conversation here this morning. Firstly, the repercussions for productivity. Mortality is the tip of the iceberg. For every case of mortality, there's an estimated 30 cases of morbidity, of ill health, which means that women may not be able to work, they may not be able to work on the fields, in the factories, proportion of cultural workers, as we heard this morning. There have been systematic impact of a maternal death on households, on household income, and not surprisingly, very large effects of the order of 1/3, 1/2 in the subsequent year. Not surprising point related to the agenda around contraception is high fertility and how that affects economic opportunities. Not surprisingly, there is a relationship of the order of 10 to 15 percentage points in labour force participation for every additional child. But then we have regions where fertility rates have been falling, where we see a more virtuous circle coming about. And Latin America is actually quite a nice example over the past couple of decades, where fertility rates fell, education levels rose, and much higher rates of participation in the economy by women. Another point also alluded to by Purnima is the link between delayed fertility and investments in human capital, what economists call human capital, basically schooling, enabling girls to finish school. In Colombia is a case where that's been documented, but there are a number of other examples around the world. And as an aside here, it's important to note that these effects can run both ways. So greater economic opportunities can also help to delay fertility and help to keep girls in school. Panim has also mentioned avoiding catastrophic costs, which can be enormous in developing countries. And the other point here to make are the effects on future generations, on children. The effects on the likelihood of infant death for those whose mothers who died in childbirth are really quite shocking. There's recent work in Africa which documented this for several countries. Let me just give the example of Ethiopia. If the mother died in childbirth, the child had only a 19% chance of surviving beyond the first month. If their mother hadn't died, they had a 98% chance of surviving. And they found similar results for a number of countries. And then a final kind of broader concept is related to this idea of a demographic dividend, of countries going through a fertility transition, having relatively more working age people and being able to reap benefits from that. That happened in Asia, for example. It's been very well documented. It was hoped to happen in Africa. It's not yet clear whether fertility rates are declining fast enough for that to be able to happen. So the question then is, given all these benefits, given kind of the importance of rights in this context, why aren't these gains coming about at a much more rapid pace? And a central part of the story which comes out is women's lack of agency, women's own lack of decision-making power. And that's something that we've been looking into quite closely more recently. And let me just give you a sense of what we're talking about here. These are decisions that women don't have at home, that they can't say no to sex, lack of sexual autonomy. They can't ask their partner to use a condom. They actually don't have any say on whether or not they can go to the clinic, no say in their own healthcare. And that's what's shown here in these three bars. Movement restricted, can't ask for a condom, and can't refuse sex. And then the fourth one is no say over healthcare. And you can see the rates here. I mean, it's difficult to see exactly, but just suffice to say that this is 50%, so very large proportions across, this is 54 developing countries, higher rates in the poorer countries, but not negligible rates in the upper middle income countries, which include, for example, Colombia and countries which are quite well advanced economically. So these figures are striking, and I think an important part of the story in thinking about kind of solutions and approaches which are likely to work, we need to be thinking about what are the constraints here. These are averages across large numbers of countries, as I mentioned. In some countries, for example, Niger, the rates are more like 82%. Mali, something like 79%, so much worse in some parts of the world, in some countries. Among the correlates of this lack of say, this lack of decision-making power, education comes out very powerfully. But the point I want to underline here that it's not just a little bit of education. What really seems to make a difference is secondary education or more. I mean, clearly primary is better than none, but where you really do seem to see the kind of, if you like, the game changing is when there's at least secondary education. Let me accelerate because I think I'm taking too long. Associated with the kind of the lack of agency, clearly are other barriers associated with accessing healthcare. Poverty, lack of transportation, these come out continually in assessments of what the barriers to care are. So turning then to what works, there are kind of promising approaches. Not surprisingly, I do want to emphasize the importance of education, and there are kind of well-documented cases where the extension of mandatory compulsory education for primary school and then for secondary school has made a difference. The introduction of transfers to enable poor girls to go to school has made a difference in terms of delaying fertility and keeping girls in school, and that's been shown quite systematically across a range of countries. A related barrier, here I'm talking about informal barriers, but there are also formal barriers as well. And I don't want to get kind of too controversial, but one point that I did want to make is around abortion laws and restrictions on abortion. There are restrictions on abortion in around 80 countries, and what that tends to do is to not kind of prevent termination, but it does tend to make it unsafe. And so there are large proportions of the deaths associated with pregnancy in those countries are actually associated with unsafe abortions, and good evidence from a range of countries where liberalisation of abortion laws has led to a reduction in maternal mortality. Changes in the health sector, changes within the health sector which, for example, facilitate access to services, conditional again on the use of particular services. There are also, I think, interesting innovations to try and improve the responsiveness of providers to women. And so payments conditional on kind of use of services for the providers. There's experiments along those sorts of lines in Rwanda, for example, which are working quite well. And then finally, not least, associated measures to improve the accountability of providers through kind of results-based approaches which ensure that they're providing appropriate services for the clients in the area. But let me stop there. Thank you.
Thank you.
So Merck loves death by PowerPoint. So I feel free. I'm going back to my OB-GYN days and not using any slides. And I'm not going to stand behind the podium because I'm conscious that there are people out there that can't see. First of all, I just want to thank and congratulate the 12 enlightened men in this audience that realize that they shouldn't go through to the panel that says impact through collaboration, because you realize something that women already know. If you want impact, invest in women, and we really are the best at collaborating. So congratulations to those men. So I've got 10 minutes, and I have 5 key messages, and you can fall asleep in between the messages because I'm going to highlight them as I say them. And the first is we have to focus on what can be done and do it. So when we talk about maternal mortality, a lot of people talk about doom and gloom statistics. But today we're saying let's focus on the opportunity that is created when we actually invest in women's reproductive health. My first doom and gloom statistic. Over the course of the time period of this panel, roughly 30 women will die while trying to give birth. 17 will be African, 9 will be South Asian, some will have children at home, some will be children themselves, almost all will be poor. But the opportunity is that of these 30 deaths, only 2 or 3 were not preventable. The rest are all preventable with things we know work. My second doom and gloom statistic. While the majority of these deaths are actually happening in the developing world, maternal mortality is actually a problem right here in the US where you're sitting. We rank number 64 out of all countries. It's one of only a handful of countries where maternal mortality is on the rise. We're behind Libya, and the rates of maternal mortality are going down in countries like Afghanistan and Sierra Leone. In fact, in the US, it has doubled since 1990. The good news, where you're sitting right now, Illinois' numbers are better than the national average. They have acted as a leader in examining why are women dying in this state and developing solutions to prevent future deaths. And they're doing what can be done, and it's working. And Merck from Others is really proud to be supporting them in this effort. Generally, though, when we talk about maternal mortality, we speak of the tragedy of women dying young, of children left motherless, and of futures cut short. But today what I like is we're turning the narrative on its head and talking instead about the tremendous economic opportunity that lies before us if we invest in women's health. That's really why Merck decided to focus its signature initiative, $500 million over 10 years, leveraging all of the company's wealth of scientific and business expertise on mothers, on reducing and ending preventable maternal mortality. It seemed a no-brainer. All we have to do is do what can be done. So we're 3 years old. We're currently working with 75 partners in over 30 countries, doing what can be done. I'm going to give a shout out to Pathfinder because they're one of our critical partner organizations that are working in Nigeria, Peru, and India, working on special innovative ways to really hit the hard-hit regions. Okay, so second message, wake up again. Investing in health helps the economy. Over the past 15 years, we have seen a dramatic reduction in global poverty. Anyone who's read Bill and Melinda Gates' letter, the statistics are in there. And this success is driven in part by improvements in health. So there may be more to the old adage, health begets wealth, than we ever imagined. According to a 2013 Lancet Commission report, about 11%, that's about a tenth of recent economic growth in low and middle income countries is due to reductions in death because of increased investment in health. And we know that healthier populations are more productive. So it's not just about stopping people dying, it's actually about stopping disease. Better health is good for the economy. And nowhere is this more evident than in women's health and women's reproductive health. Now, I could throw a lot of data at you. I personally don't think you need to be convinced that healthy women means healthy economies. But I'm going to instead use a story, and that story is of my mum. So my mum was born in a village in North India. She was one of 7 children. Actually, there were way more, but they succumbed to the high infant mortality rates. And she happened to be her father's favorite child. So he decided to invest in her, keeping her alive, in her health, and because the boys would refuse to study, he decided to invest in her education. And she went on to be the most educated girl in that village. So when my father came from London, it was obvious that she was the one he was going to pick. So they moved to London. Now she's healthy and she's educated, so she immediately gets a job and starts contributing to the local economy of her large extended family of in-laws, as well as to the UK economy through tax. And she realizes, because she's educated, that she can't have a child straight away, though the pressure is on. She needs to figure out this stranger that she's just married and figure out a new country. So she surreptitiously uses family planning, sorry, grandfather, and waits as long as is socially acceptable, and I was born. She realizes as soon as I was born that she cannot give me what her father gave her unless she goes straight back to work and works for as long as possible to give me health and education. So now in cahoots with my father, who she's brought on board, they actually use family planning for 6 years, and my next sister, much to the chagrin of the family who wanted a son, was born 7 years later. Now I tell you this because she gave me the best thing she could give me, which was a strong education. But she gave it to me because her father decided to invest in her health and her education. And I got it because she decided to have access to reproductive health services. My mum was actually born in a village in UP, which continues to have the highest maternal mortality rate in India. And through that education and health, she contributed to the economy of 2 families, continues to contribute to the economy of 2 communities, and has contributed to the economy of 3 countries: India, the UK, and now through me, the US, with my tax dollars. I say that because it's a tangible example of my third message, and that's investing in women's reproductive health specifically has direct and dramatic social and economic benefits. Burnham, you mentioned the statistic. I'm going to repeat it because I think it's important. Every dollar invested in women's reproductive health services generates $120 return on investment. From a business perspective, that is a no-brainer. If I told you I had a stock that would guarantee you to generate $120 for every dollar you invested, well, you'd be calling your broker right now and we wouldn't need the panel. But really, I want you to imagine when you leave this room what unlocking that kind of potential could do in terms of ending poverty and generating economic growth. My fourth message: family planning is a game changer, not just in reducing maternal mortality, but it has huge economic benefits as well, and my mum's story is again an example of that. So we're aspiring to end preventable maternal mortality, and we know at Merck for Mothers that family planning is key. If we can meet the unmet need for family planning, we will reduce maternal mortality by, at the very minimum, 1/3. So that's why with the Gates Foundation, we had a $50 million partnership that basically one of the early projects in Senegal, and I get goosebumps when I just got these statistics, we're 14 months in, and with a supply chain innovation working with the government, we have managed to reduce stockouts from 85% to less than 2% in 2/3 of the country. That's working with an excellent partner on the ground called IntraHealth. But most importantly, in 1 year, we have seen the contraceptive prevalence rate go up by 4% to from 16 to 20%, and the Ministry of Health is aiming for 27%. So we're well on our way. We can make a difference, and actually we can make a difference really quickly. Now, in addition to saving these lives, if we ended all preventable maternal newborn deaths, we would unlock an extra $15 billion in lost productivity every year. No company is going to sniff at that kind of revenue. And this is a generation of dollars in developing countries that would boost the economies of some of the poorest places on earth. Okay, so my fifth message, because I'm being told I'm running out of time. Before my fifth message, I do want to say the other case for investing in maternal health is to have a healthy mother and a safe pregnancy. You need to have a functioning health system, all the way from primary care to emergency services. And a functioning health system is critical for a global healthcare business like Merck. Okay, my last message. There is an even better case for investment when you consider that women are the world's next and largest emerging market. Women own more than 1/3 of enterprises worldwide, and that number is growing. Women's incomes are expected to grow by nearly $6 trillion over the next 5 years. And investing in women is investing in families and communities, like my mother's story, because women invest 90 cents of every dollar into their family needs, compared to 30 to 40 cents for men. So not only is investing in women's reproductive health talking about investing in children's health, the future and economic securities of the next generation, and countries' economic growth. But to all of us at Merck, the math was pretty simple. Invest in women's health, you'll have healthy families, healthy communities, and healthy economies. Quite frankly, that's really good for business.
I know the audience is rearing to go. We've heard so much, and Priya, thank you, and Jenny, thank you for your presentations. But I have just one question each. I had more, but I'm not going to ask them. One question each for both of them, because I think it's important to bring those issues in the room. We've talked a lot about returning to investment in women's sexual and reproductive health. But do these positive benefits go up even more when we provide those services to men as well? And I'm going to turn that to Jenny. So can you tell us what the limitations are if we focus solely on women?
I mean, I think the evidence is clear that focusing on women will often risk bringing partial results. And I think particularly when you're thinking about the underlying constraints around norms and the need for normative change, and kind of households and families and contexts within women are really quite disempowered. It's not going to change without changes on the part of men. I mean, there are approaches which, if you like, avoid men. So, for example, there's a reasonably successful program in Zambia with concealable contraception, but there are also risks involved in those approaches in terms of kind of retaliation and violence and so on. And I think the good news on this front is that the evidence is accumulating here as well. There are movements, there's a global movement called Men Engage. There are initiatives at the local level, Promundo in Brazil, Sonke Justice in South Africa, which is showing what can be done, in particular working with youth. So I think it is a very important part of the puzzle, and it's something which often tends to be either neglected or just have lip service. But the more effective programs in terms of changing norms are very much community-based and very much engaging men as well.
Thank you, Jenny, and I'm glad we made that clear, that we do believe, all three of us, that it is important. If you want to change gender norms, if you want to make a change, you really have to focus on both men and women, and particularly on the younger generation. I'm going to turn to Priya now. I think you've teased people's appetite a little bit in terms of Merck for Mothers. So I'm going to ask you a question. Most people in global health assume that health is a public sector responsibility. But tell us what you've learned from Merck for Mothers, your in-country programs that may have sort of shifted the paradigm, especially you said a little bit about what's in it for the company, but tell us a little bit more in terms of how that case was made, for example, in-house, and what brought Merck on board, so we can inspire a few more companies here to come on board as well.
Okay, so I want to make sure the audience has time for questions. So I'm going to be brief, but do catch me afterwards. I think in terms of maternal health and the public sector piece, you're right. The dominant narrative is maternal and child health is a public sector responsibility. They've always been a public sector responsibility, and we need to keep investing in the public sector until we get this right. And I trained as an OB-GYN in the UK, the National Health Service. That made sense to me. But what I liked about Merck's approach is it's all customer focused. So they said, well, go and find out what's going on the ground. And I go into India, and I keep being told 80 to 85% of India's population goes to the local private provider for healthcare. And I was like, okay. And then we looked at the statistics, and 50% on average across sub-Saharan Africa goes to the local private provider for healthcare. Well, if you just look at it from the customer perspective, if that's where the customers are going, why are we investing only in making the public sector accountable to deliver high quality services? But I wanted to know where the women were going. So what we did is we actually asked the London School of Hygiene and Tropical Medicine, not because I was doing my PhD there, to actually look at the data in 57 countries. And they found the same thing. Women are going for family planning, prenatal care, labor and delivery to the private provider. So our programs, and I understand there's ideological barriers, but we're basically strengthening the local private sector to deliver high quality, affordable healthcare services. Now, Pathfinder is a great example of this. In countries like India, that doesn't mean you just strengthen the private provider. It has to be a network of services. But if a country like India wants to achieve universal health coverage, with 90% of its population going to the private provider, they can't do that with only working with the public sector. So I'll share a little anecdote on that, and then I'll go into why Merck. So people always ask, in India, it's really weird that a woman would go to the local private provider when in India you get paid 1,400 rupees to deliver in a public sector facility. And these very, very poor women are still choosing to go to the local private provider, right? And it's because they're accessible, they're embedded in their community. The same provider in the public sector will treat the woman better in the private sector. Right? So there's obviously a desire to go there, and we have to ensure wherever women seek care that they get high quality care. Quickly on the Merck thing, because I did address this, beyond the obvious, which is reputation, we're a socially responsible company, and the 70,000 employees all have a mother, and motherhood and apple pie. This initiative makes employees more engaged, more productive, more proud of the company they work for. But as I said in my notes before, it's three things, right? You invest in keeping women alive. They're the decision makers for healthcare. Just come bring it back to Merck, right? They're the decision makers. You fix a health system. You need a healthy system for a global healthcare business. And then you're fixing the economy. Well, poor countries can't buy Merck products. So we need strengthened economies. The piece that I'm trying to get them to understand, it wasn't designed for this, is where women are dying in pregnancy and childbirth today are the markets of tomorrow. And there's a lot of lessons that can be learned to actually benefit the company if we think about it like that. But that's my very short response as to why I think initiatives like this are important for business.
Thank you, Priya, Purnima, and Jenny for a very interesting discussion. I'm Megan Lynch with the Chicago Council, and at this point we'd like to open it up to you for audience questions. We're going to take two together. We have about 7 minutes left, so we want to get in as many questions as possible. So please raise your arm, introduce yourself, wait for a mic. So right here in the front row in the purple.
Hi, Antoinette Gavin. I don't know, there we go. Hi, Antoinette Gavin. First, thanks for the tremendous work and the tremendous presentation. I'd be interested in your observations on what I see a shift in the U.S. To actually restrict reproductive rights and make it difficult for women to access birth control and basic services. So we're making this progress around the world. Any thoughts on what we can do here in the U.S.?
Thank you. And before we answer that, one more question from the audience. All right, in the back there, right there.
Hi, I'm Janae Terry, and I just wanted to know, why is the maternal mortality rate so high in the U.S.? Does it have to do with better reporting, or the prevalence of chronic diseases like diabetes that mothers might have before or during pregnancy? So
thank you, Priya. We're almost out of time, so.
So as the resident Australian in the room, I can have an independent point of view here, not affiliated with any kind of particular institution. It's clearly sad, and I think distressing, and I think also surprising given the strength of the women's movement in the US. And one of the kind of stylized facts from around the world is that women's movements and advocacy play a tremendously kind of important, positive, progressive role in enabling reform on a whole series of fronts. And so I think kind of continuing to lobby, to advocate, to show the costs of ill health, the costs of unsafe abortion are all very important, and to kind of guard against reversals. But it is a puzzle. As you might know, US is one of 6 countries, I think, in the world now who didn't sign CEDAW, the Convention for the Elimination of All Forms of Discrimination Against Women. The other countries are Palau, Somalia, and a couple of others. And I think that, that is symbolic as well. Whilst the US has made enormous progress, I think, on other aspects of women's rights and opportunities, I think this is one where, it remains problematic.
So just to answer the US question, and I can give you more detail afterwards, but there's three main issues. Just because better reporting, CDC feels that's only contributing to 5% of the increase. So this is not a better data issue. In fact, one of the problems in the US is that we don't have the data. So anyone who works internationally will probably be shocked to know that maternal mortality reviews are not standard place in the US. Only half the states in the US actually do review maternal deaths, which is supposed to be a never event. And only half of those are functioning. And that's really abhorrent, to be honest, because countries like Sri Lanka and India, we're spending a lot of global dollars to make sure those countries do maternal mortality reviews. So one problem is we don't know till we start reviewing those deaths. Illinois is a leading state in that. The second issue is, and again, I think the people who work abroad will be surprised by this, is the quality of care that a woman receives during pregnancy and childbirth here is completely inconsistent and a bit of a zip code lottery. So depending on which hospital you go to, which city you're in, sometimes which doctor you see in a hospital, you will receive all kinds of care for the three major killers of women during pregnancy and childbirth. And we all know that variation leads to harmful outcomes. And so we're working on that in 5 states, reaching 3 million women, to show the US government that it can be done. And I'm pleased to report the US government has now endorsed those protocols for those 3 killers and is taking them to another 10 states. And then the third thing is what you highlighted, which is pre-existing conditions. Women are entering pregnancy sicker. They often only have coverage for pregnancy, so we're working with community health workers to say, you are kind of the nexus between healthcare service delivery and public health, and how do you bring those needs together? So we're addressing all 3 in our programs, and I'll be happy to discuss, but I think there needs to be a lot more advocacy in this country because a lot of people are not aware that maternal mortality is on the rise.
So we have a hard stop at 11:15, but we have time for one more brief question. So anyone in the audience? Right here in the back. Wait for the microphone, please.
Thank you. Can you just tell me what new developments have been made to help with fistulas?
Can you hear me? Yeah. The good thing is that fistulas are now being considered as part of an issue that needs to be addressed. One of the things that we know is very often fistulas occur when the woman, or I shouldn't even say woman, when the pregnancy is with a girl. When a girl is having pregnancy, her system, her biological system is not adequately developed. She goes into labor and she has extensive, long labor, due to which often fistula is caused. Now, there's a lot of social reasons for why that happens, and we've gone into it a little bit in the session, so I don't want to repeat that. But I can tell you, I can assure you that in all programs, for example, that Pathfinder works on, as well as many of our other partners, fistula is an area that we are beginning to focus on more and more. And countries are taking it on board through working with community-based organizations. But for all of this, again, we come back to it's a very fixable problem, by the way. There are surgeons, there are doctors who can be trained in terms of fixing it once it occurs, but what you need to address is to prevent it. It's a very preventable condition, and unfortunately, that's the area that doesn't get addressed adequately because it's very much linked to gender norms, the age at marriage, the situation of girls in that country. So all of these areas are areas that we take on.
Just to add, because prevention is key and there's lots of social cultural norms that need to be addressed, like you said. The one thing that they're doing, so prolonged labors lead to fistula, as you know. And actually, there's a very exciting initiative between WHO and Gates the chart that allows you to manage labor appropriately in a time-responsive way was developed from the science of 100 women in New York, which is evidently not going to work in Africa and Asia. So they're actually using great research and likely artificial intelligence sort of, I won't go into the networks, but basically they'll be able to create a personalized obstetric management chart, which we'll then put on our digital platform. So rather than just saying, well, whatever works for a woman in New York 70 years ago works for girls in Africa, that situation will be prevented. And one other thing that I think is important in terms of management of fistula is for a long time we relied on surgeons. So like myself, I train in fistula surgery, etc. But there aren't enough of us in many of these settings. So what I like is some programs have introduced task shifting, and often it's the women that actually had fistulas themselves and over time can be trained to do that surgery. So just a couple of sort of innovations.
Unfortunately, we are out of time for this panel. We can talk afterwards, but thank you so much to our panelists. Please join me.
Ladies and gentlemen, if I may ask you to please take your seats. I can't tell you how overwhelming it is to see such an enormous crowd here focused on these fantastic issues and things that are of importance to all of us. My name is Laura Linger. I'm with William Blair and Company here in Chicago, and I also happen to be a member of the steering committee for the Women and Global Development Forum, and I work on the steering committee at the Chicago Council on Global Affairs. I think I was perhaps the right selection to introduce this panel because I also work on the Tiffany Circle Women's Leadership Society at the American Red Cross. At William Blair and Company, obviously, as a financial organization, we care so much about big data because it is absolutely critical in terms of the way that we do our business. So I'm delighted that all of you can join us today. But to the more serious issues, earthquakes, outbreaks of disease, and tragedies can be very difficult to predict, really, and even more difficult to respond to for institutions that are caught unprepared. As data becomes more available for widespread usage, there's an opportunity to learn from these mistakes and successes, and to also better predict, based on some of this data, where help may be needed in the coming years. Today's panel features 3 experts who approach problem solving from very different perspectives. They will discuss the kinds of data available, ways to use it, and also some case studies on Ebola and climate change. These problems directly affect women in so many areas of the world and are very near and dear to all of our hearts. You have a copy of their bios on your chairs, but let me briefly highlight a few points and highlights of their prestigious careers. As the Chief Operating Officer of the American Red Cross of Greater Chicago, Harley Jones has joined us today. He oversees disaster and community support services for over 9.6 million people and serves as a trainer for the American National Red Cross in the area of international humanitarian law. Our next panelist is Andrew Schroeder. Andrew is the Director of Research and Analysis at Direct Relief, which is a not-for-profit organization that provides medical assistance around the world. During his time there, he has implemented an array of projects demonstrating programmatic impact, such as mapping global prevention of mother-to-child transmission of HIV and AIDS. Our next panelist is Joan Sukumel. She is a director and architect at Skidmore, Owings & Merrill, LLP, and is a senior medical planner for Skidmore's health and science practice. During her career, she has designed architectural projects that serve the needs of the specific healthcare and science communities. Joan will lead the conversation on stage today and also walk us through the case studies that the panel has assembled. Please join me in welcoming this prestigious panel.
So thank you for that introduction. In terms of big data, how do we understand that? And big data has popularly been defined as in terms of volume, velocity, and variety. Volume, because it's the sheer amount of it has increased over the last few years. It's coming from a lot of different sources, using your anything from your iPhone to transactions that you perform, sensor-equipped buildings and sensor-equipped devices. All this data is flying in from all kinds of different directions. In velocity, it's coming in at unprecedented speeds, which means that we really have to find ways to deal with it in real time. In variety, it could be structured in terms of numeric database or unstructured in terms of cell phone transactions or financial transactions, and it comes in various formats, so it makes it a little bit of a challenge to use sometimes. But the real revolution in big data is not about the quantity, but the fact that we can do something with it now. We have ways of computing it. We have ways of looking at it in terms of statistical analysis. And we also have ways of linking data sets so that we can overlay different kinds of data and look at how we can generate new insights that way. We have new creative approaches to visualizing data. We're going to share that with you today, in which we can see patterns maybe that computers can't see. So my firm is interested in big data in terms of how we can develop healthy cities with that, and we're really seeing a lot of potential in terms of that. But in terms of the potential for using data to do good, it's nowhere greater than in the realm of public health. So I think we're right in the right place with that right now. I'm going to turn to my panelists and have you each tell a little bit about your company and what you're doing, or your concern in what you're doing. So Andrew, if you'd like to start.
Sure. Thanks. So, like the introduction said, Direct Relief is a NGO, nonprofit organization based in Santa Barbara, California, which particularly on days like today is just a lovely place to deal with global disease and poverty. And you know, we deal with distribution of essential medicines and medical supplies around to local communities around the world. We do this for global health, alleviating global health problems. We also deal with disaster relief a lot, and you know, when we're looking at the value of big data in what we do, we're looking at several different dimensions. We're looking at sort of how we can best be as maximally transparent as possible. So being able to collect information, distribute that information in a way that matches standards-wise to what other people are doing, so that we can contribute to the aggregation of that around the world in an effective way. And then to think through, particularly for disaster and say pandemic preparedness, around social vulnerability analysis. So vulnerability is a multifaceted concept. It involves physical risk, it involves social inequality, it involves epidemiology, it involves changing factors on rapid timeframes, and being able to link that and to do that in a pragmatic way, and to do that quickly, and to do that in a way that really stitches together with programs is something that I think has only just very recently become doable, and doable by an organization like ours, which actually doesn't have a tremendous amount of people that do that work, but people collaborating with computers are and able to sort of link up data sets that we weren't able to do before, and to think intelligently about how we're strategically placed around the world. So,
Thank you, Harley.
Great. From the perspective of the American Red Cross, is this on? Can you hear me? All right. The American Red Cross and Red Crescent as a movement around the world exists in 189 countries, and so to be a representative here of that organization is relatively significant. At the same time, to think about a world in which big data, thinking in terms of big data for us, we're a 130-year-old movement. Thinking about data for us sometimes is very difficult. We're a very old organization. And in every one of those 189 countries, the work of the Red Cross or the Red Crescent looks different at any given time. In places like Tanzania, the Red Cross, Red Crescent might be running the ambulance service. Here in the United States, that means using big data as the single largest provider of blood and blood products in the United States to create a sophisticated logistics system to ensure that we can meet those needs anywhere in the United States. 2, women's health. And the 14 families and the 14 mothers last night in Northern Illinois that we provided with assistance because their home burned down, or because they had to evacuate because there are oil tanker train cars on fire in Northwest Illinois. That impacts women every single day. And so for us, big data provides 3 opportunities in particular that I want to highlight before we move forward. The first one is around efficiency. How does a 130-year-old organization become more efficient living in big data? That's the biggest opportunity for us. The second one is what kinds of data live out there in the open source world that our partners, our friends, our governments are collecting that can actually make our programs at the end of the day more efficient for the people that we're working to help. This could be as simple as using City of Chicago data to tell us where children and people are dying because of house fires, so that we can then send teams into those neighborhoods to try to alleviate that. And then the third piece is the opportunity to engage new volunteers and a new generation of people in our 130-year-old mission. So that means for the first time, being able to welcome with open arms civic activists, people who are data scientists, people who think differently about the world in terms of data, so that we can impact the people that we serve at the end of the day.
Great, thank you. It's impressive. So we're going to show you how to a couple of case studies, a couple of clips, and how we can visualize big data. We're going to start with an Ebola case study, and we're going to zoom around the world to the ground zero of Ebola, which was in a small, remote area of Guinea, but very close to the borders of Sierra Leone and Liberia. And we can overlay that, looking at ground zero, and say, okay, where are the roadways, for instance, and the other infrastructure, and how might that affect the movement of these cases, and where are the big areas where people are gathered together in clumps in urban areas. And then we can overlay the regional healthcare, the existing healthcare locations, and as you see, the red dots are in Liberia, the blue X's are in Sierra Leone, and the blue triangles are in Guinea. So you can see there's an infrastructure there already, which may or may not answer all the questions, but that's a good place to start. And then you can go into the Ebola cases by sub-region. You can look at where the hot spots are. The biggest caseloads are in the dark red areas, for instance. And you can look at, then we can overlay the emergency telecommunications clusters that are responding to Ebola, and we can see where those are if they're located in actual specific areas that are helpful to the case. In each of these areas, and we can zoom into data, we can look at an area and say, what is the propensity of cases there, and how are those cases, how severe are those cases, what are the quantity of those cases? And we can also look at a global view of Ebola in terms of trade routes and travel routes and helipads and response areas, facilities that have been put in for Ebola. So I'm going to stop there and ask Andrew and Harley a couple questions on how this might affect us. And Andrew, how can we use this data?
I think we can use it in a lot of really interesting ways, actually, and the map you're looking at right now is one of the more interesting ones about sort of why the Ebola crisis happened in the way that it did. And just to pull back a little bit to what we were talking about earlier about, say, vulnerability as a multifaceted problem. You're looking at a set of layers that are landscapes that allow you to think about the world from a number of different points of view, and to do that simultaneously and look for correlation and causation across those layers. So the first layer you were looking at actually showed Meliandou, which is a small village in Guinea that is in a remote area. It appeared remote. It's actually largely forested, although there's been rapid deforestation in that area that also would show up if we were to time sequence some of these things. And that has been part of the pattern of Ebola since we first detected it in Zaire in 1976, that it's a disease of remote areas. But the remoteness of Meliandou is actually proximate to a set of newly newly urbanizing and very dense areas connected by, if you see that big red road that goes down to Monrovia, which is the Liberian capital on the coast there, a set of rapid population transfers. Monrovia is a city of over 1 million people, and that was really the defining change that happened in the Ebola epidemic, was that dynamic between remoteness and proximity. And we can see this actually emerge in the data as we sort of look back over the course of the Ebola epidemic, that dynamic between areas that are, if you were from the viewpoint of a fruit bat, look like really good places to be, particularly because those are what we call zoonotic reservoirs, or places where you're much more likely to come into contact with animals that are going to be transferring diseases to human populations. And those populations are then linked into infrastructure networks and population networks that are likely to spread those diseases through human networks. One other quick point about those air roots. They look very nice and thick and strong, and that was actually one of the key problems that we had early on in the outbreak, was that those air roots were actually shut down into the affected area, and that whereas on the ground trade routes were actually causing viral spread, the trade routes through the rest of the world were largely disconnected, and that became a significant problem for the relief effort. So we had to rapidly move material into that zone, and were sharply curtailed in that effort by the way in which infrastructure networks globally were transformed as a result of perceived risk and perceived transmission into capitals in Europe and in the United States. And so that dynamic between perceived global risk, interconnection, and rapid response requirements within landscapes like the one you're looking at, I think are going to be one of the really critical issues for pandemic preparedness and response going forward. We have to really get a lot smarter about that much faster if we don't want a repeat of what happened in West Africa.
So Harley, do you have some other examples of how this data is being used by the Red Cross?
Yeah, I'll point out two things in particular. So as this data begins to inform the work of our colleagues at an international level, we begin to then overlay data around mortality, and we begin to look at not only the constant work that our organizations in those individual countries are doing on a daily basis, but as international consensus and resources build around additional programs in support of this, two things really became apparent. Number one was that mortality rates, there was a direct correlation between that, the burials, and the customs and practices in some of those countries. And so the Red Cross as a movement, the Red Cross Red Crescent as a movement, saw a very specific place to be able to step in and provide targeted strategic ways to actually provide those burials to help try to curtail that correlation as much as they could. The second piece, and I think I'll talk about that at the end of this data set in particular.
Okay. Would you want to add anything about how this ties directly back to women's health?
Yeah, absolutely. I mean, I think it's important to remember that the Ebola outbreak in many ways has been principally about women's health. You started off by talking maybe a little bit about, and this has been echoed in other panels, about caregivers and the way in which caregiving has been principally a mode of transmission in the Ebola crisis. And that's largely a gendered phenomenon in West Africa and many other places. And it's important to bear in mind when we think about moving the profile of this over into other places. So if we were to extract from this and think about, okay, that's not unique here, that's actually something that's systemic in a lot of other places. So let's bear it in mind as an input into our algorithms as we think about risk in the future. But also think about an article that just came out in Nature earlier in this week where they pointed out that what was previously unknown to me, that, and they focused on the April to September time period, but that 1/3 of the health workers that died in the Ebola outbreak from April to September were not Ebola specialists. They were maternal and child health specialists, and they were people that were dealing with pregnant women, women in delivery who are at elevated risk for a whole variety of reasons for transmission of the disease. And that hasn't necessarily been kind of thought through in terms of systematically what do we do in terms of recovery, in terms of how we think about what it means to respond to an infectious outbreak, that these are not sort of different areas of health. We may treat them that way programmatically. We have different pools of money for them, but they're intimately linked in terms of what actually happens on the ground. Infection and safe delivery services are two parts of the same process. And then lastly, obviously, Ebola has been a system crisis, and we'll come to this when we talk about climate change too, just to forecast for you a little, that system crises affect everything. And here the ripple effect of the disease was much greater than the disease itself, even though the disease itself was horrific. And so access to basic healthcare services throughout all of these three countries has been dramatically impacted, and that has meant delivery services, that's meant vaccination, that's meant child nutrition, that's meant everything. And so we need to really be able to back up and think through that system level when we look at the data on response.
And I think to Adam's point, when you talk about systemic failure of what's happening around these crises, this is the second piece that I want to highlight from our perspective, is that we then took this data about what the crisis looked like and were able to overlay it with data around the economic disruption that it created. And so that data began to show us three categories of individuals that needed direct assistance that the Red Cross Red Crescent Federation could affect. Number one was individuals who came down with Ebola, were treated with Ebola, and were cured of Ebola in some way, shape, or form. And so at the end of the day, what did that disruption look like for them, looking specifically at the economic disruption? The second one was families who had a deceased loved one somewhere in the community from the disease. And then the third one was people with family members who were deceased at one of these treatment facilities. And so this informed the larger development of a cash assistance program from the perspective of the Red Cross and Red Crescent Society to directly have an impact on that economic disruption to these families who may have lost someone who may have been disrupted by this. So the data then took us to other steps. How do we determine what that cash assistance looked like? We were able then to connect it with the data based on market-driven prices in that given country, in that given region, so that the cash assistance we are actually giving out on a daily or weekly basis is tied to the money that they actually need in the region that they actually live in. And then finally, the last one in particular is using data around the proliferation of technology in these places. And so sub-Saharan Africa in particular, mobile phones are everywhere, not smartphones, but mobile phones. And so the use of and the leveraging of the SMS technology around text messaging to actually distribute financial assistance that way instead of more traditional methods that would have been difficult in this kind of an environment.
Okay, so thank you. We're going to wrap our Ebola study and move over to another part of the world. I don't know if you have some overlay statements as I go through these slides. Andrew, feel free.
Just to pick up one thing, and I hope we can get a chance to talk about it too, as we think about like connections across locations. And I think this is one of the things that big data really should push you to do as a practice, is to be synthetic in your approach. Don't think about just the data point, think about the trend, the map, how this extends over a lot of other potential areas. It doesn't have to be a formal model where things pop out, but you know, throughout sub-Saharan Africa, for instance, if you take my earlier point about the dynamic between isolation and proximity, you know, according to the United Nations population statistics, which I'm not sure we all, you know, read avidly, the next 35 years or so, we'll add another 2 billion people to the world population. About half of those will be in sub-Saharan Africa. That's going to place stress on resources. That's going to place stress on forestation. That's going to bring more and more people into contact with zoonotic reservoirs. That's going to increase the problems that will result out of areas that are dense slum areas, areas where you have informal settlements proximate to major commercial centers, and where housing prices, say, have made it so that it's very difficult to sort of transform those into formalized settlements. So those kinds of dynamics are places where we are not just in Guinea, they're not just in Sierra Leone, they are throughout the continent, and we need to really be clearer about how the data can help us get out in front of those problems so that we don't find ourselves caught in some sort of Groundhog Day where we wake up and every day is December 13th, 2013, where we're about to experience the worst epidemic ever.
Okay, meanwhile, while Andrew was talking, we've flown halfway across the world to the Philippines. So this is another clip that we use using open source data. And it takes a look at the effects of climate change on areas like the coastal areas of the Philippines. And one of the things my firm is doing is looking at how that might change over the course of the world in terms of climate change for sea levels rising. So we can look at those areas that might be affected by that and anticipate how we might be able to plan from an urban planning standpoint how to avoid problems and be preemptive rather than reactive. So this happens to be what we call a bathymetry map of the Philippines, and that's showing the mapping of the ocean floor, which is useful for looking at how tropical storms might react, but it's also just kind of a cool graphic. So this is mapping the low elevation zones of the Philippines and protected habitats. And if we zoom into Manila, we can see that these red areas represent areas that are 10 meters or less height above sea level. So if we're looking at a sea level rise of what they're predicting in 2 to 5 meters, we can see that there's some areas that have critical responses that are necessary in order to deal with. When we look at the population, in order to deal with these populations, because the darker areas on the map are showing in population density. So you can see there's an overlay of the low sea levels as well as the high populations. So somebody, obviously we need to be thinking about this. In agricultural production, in terms of how is that affected if the people from the low-level areas need to migrate? How might the agricultural areas be affected by these sea level changes? And we can overlay that with road and water infrastructure and understand that a lot of this data is available from the cities. They're mapping quite a lot of this themselves. So we can see that the white lines are the road infrastructure and the blue lines are the water infrastructure. And there are water testing stations at the red triangles. So there's some infrastructure there that's anticipating some of these problems, but there's still issues that need to be dealt with. So in terms of the land use, we can also relay that and understand what's happening in those particular areas. Are they residential areas? Are they industrial areas? Are they other kinds of uses? And that also provides us some information as to what's going to need to be dealt with in terms of the population. And we can also look at the effect of flooding from Tropical Storm Ondoy. So this is a map that shows the red areas are the most intense areas of flooding. So that might be a way to anticipate in terms of another storm that might come along, what needs to be dealt with to prevent some of the losses that that storm provided. And just backing out to regional Manila. And then we try to think about big data as providing big ideas and big solutions. So that is the hope as we end up dealing with, or as we look at how we can understand these open source data opportunities. And I'm going to turn back to the panel and ask Harley how the Red Cross looks at climate change risk.
Thank you. And as a representative of the Red Cross Red Crescent organization in particular, I want to highlight some research and some kind of paradigm shifting work that my colleagues are doing at what we call the Red Cross Red Crescent Climate Center in The Hague. And this is very specifically referencing an article in the Journal of Natural Hazards and Natural Disasters that came out in 2014. And this is around how do we look at this data, not in the next 2 years, not in the next 3 years, not the next disaster, but how do we change the paradigm in the next 20 to 30 years to look at a very specific stat. And that is that as we look at big data, 189 countries worth of data from a Red Cross perspective, we found that only about 12% of funding around disaster happens pre-disaster. And so the paradigm that we're trying to kind of flip on its head is there a way to take this long-term data and create what we call a forecast-based financing system that turns that stat on its head? Can we do a very specific cost analysis to say, if a forecast is telling us that floodwater is going to hit here and that there are high-risk populations of women and children and elderly or people without access to food and water, if we take very targeted steps when the models tell us to, how can we actually make a bigger impact not only on how they're affected by that disaster, but actually making it cheaper in the long run for us as the world to begin to fund these things on the front end of a disaster. So that's really the question that we continue to ask. A couple of examples of that we started to see. And I'll use the example of Kenya in particular. Using this long-term climate change data, it tells us that if we take very specific actions, not in the country of Kenya, but it might be village by village. If there's a 30% chance of a flood in this town based on the data that we have, if we take action step number 1 of beginning to dig trenches around the local river, if we take action step number 2, what is the cost analysis, how much cheaper is that, and how much less of an impact is that long term? So these are really starting to drive these questions for us, and can we flip that on its head? And then can we convince the larger world that making a larger investment on the front end of disasters in the long run is actually cheaper and less disruptive to the overall area? The second piece to that is not only how do we create funding cycles on the preparedness side, but there's a functional and there's an actual operational component to that. how do we create standard operating procedures for organizations in countries where this is going to become more prevalent around climate change? And when you get down to women and children and families, are there actual steps or preparedness issues that individual families can take to help avoid the largest pieces of how these things are going to come to impact them and their families at the end of the day?
Andrew, how about your work with Direct Relief on climate change?
Well, we're a health organization, so I don't know that we can't stop climate change, but although we'd like to.
Well, how you respond to it.
No, sorry, just a joke. One of the things I think is important to bear in mind, and I love the emphasis on preparedness that you just talked about, since climate change largely, particularly from a health point of view, is a preparedness, and in the jargon of the field, a resiliency issue, where what we're trying to do is look at likely future systemic impacts and design against them. And we can design against them by being able to identify where is the health infrastructure that is going to need to serve people that are likely to move, are likely to be affected. Extreme events at frequencies and intensities that are beyond what we might have considered to be the normal in previous generations. And the great example of that in recent times is your example from the Philippines with Typhoon Haiyan that really dramatically changed the context in the Philippines for what is considered to be a possible event. Typhoon Haiyan, it's not that the Philippines did not have evacuation centers beforehand. It's not that they didn't have relatively good plans on the books, and this is one of the reasons why it wasn't even worse than it was, but that Typhoon Haiyan was of a threshold, or beyond a threshold, that was beyond what was planned for, and by a big margin, particularly in the city of Tacloban. So how do we incorporate the black swan event in statistics parlance into thinking about the possible? What are the worlds that could exist over the next 50 years? And this actually starts to enter some nuance into the forecasting question too, right? I mean, we can't spend money on every possible future. We can spend money on some possible futures. How do we determine, based on the data, what's reasonable? And all the while knowing, and I hate to admit this as someone who actually runs these models, but we're going to be wrong. We can only plan for so much. So, and this is really important, and I want to bring it back as well to the model that Direct Relief employs is to really work with local people and listen to them in terms of what their needs are. So. This goes to, I think, a philosophical question in some ways around both programmatic design and data. So data is a social product, like anything else. It's produced, it has to be paid for. It doesn't just happen. We don't just pluck it out of the air. It has to be built. It's built on standards, and it's built in ways that have tended to preference some ability to collect data over others. And that has meant that the data doesn't contain certain things that it probably should. There are certain voices that don't get found in the data. So, recently there's been a process within the Philippines around being able to design against coastal risk by being able to create setbacks on the coastline. That is a reasonable response to elevated sea rise in a number of ways. However, it's complex because the majority of the livelihood by people that are poor and coastal is through fishing. It requires proximity to the coast, and the services that have been designed are also proximate to the coast. So if you set people back trying to create my own disaster here. If you set people back from the coast, you transform social structures. You transform their ability to make a living. You transform access to healthcare. You transform the amount that women have to travel to have a baby. And all of those things have to factor into your model. You can't just say, I understand physical risk and I understand water levels and think that your job is done. It's only just begun. So that, I think, is the real challenge that we face now.
And the only piece I would add to that is, and I kind of made a joke a few minutes ago to say that we kind of plan for being wrong. But the point that I make is we know there will be pockets of data that don't inform us or that will allow people to slip through the cracks. And so my point is that we need to plan as organizations, as volunteers, as anybody, to be able to be nimble enough to shift on a dime when this family or this mother or this community needs something just a little bit different than the overall infrastructure that the data has given us. And that's the piece I want to highlight.
Okay, I'm going to skip the rest of my questions for the panel and turn it over to the audience to ask questions.
Great. Thank you, Joan, Andrew, and Harley for a very interesting discussion. I'm Megan Lynch with the Chicago Council, and we'd like to open it up to the audience for questions now. So please raise your hand, wait for the microphone, and introduce yourself. So back here.
Great. Hello. I'm Ellie Burgess. I'm a student at Northwestern University, and I'm particularly interested in how big data, like just gathering it, affects the environment. So there's huge server farms that are processing this information, and as well as functioning in the cloud and all things like that. What are your companies doing to address the environmental impacts of big data?
We're doing nothing at all because we have no control over that. But I think it's a good point that, so it goes to my point earlier that data is a social product, right? It's got to live somewhere. It depends on power infrastructure. It depends on network transmission capabilities. Those networks have to be built and maintained, and all of that has a price in financial terms. It also has a price in ecological terms. Some of the companies, I know Apple has been moving in this direction, have started to move their data centers off grid, so essentially running them off solar and other ways to actually offset the power consumption. In California is a particularly egregious example of this. I mean, a shocking percentage of the total utility bill in the state of California comes exclusively from running your Facebook pages. So that's something that's important to remember, and that's going to get worse. I mean, there were something like I believe the stat is that there was more data produced and consumed more energy in the last 2 years than in all of human civilization. Now, of course, a lot of that was cat videos, but it's still important to bear in mind the scale.
Those are important. Yeah. Okay, great. Next question right here in the front.
Thanks for this. There's a lot of fascinating stuff when you look at these macro systems and you're dealing with some really big problems. Do you have any thoughts on how you make this accessible, this kind of the insights accessible for people who are trying to make policy changes locally who may not have the infrastructure and resources to go big, so to speak?
I would start by talking about from our perspective. We are an organization, as a nonprofit organization, that puts all of our resources into the hands of the people that need it. And so we have, I would venture to say, almost no ability to make large-scale investments in this kinds of work, which often means that the things we get come from one thing, and this is the answer that I think I can bring, is that it's about collaboration. And so at the end of the day, these tools and the data are only as good as the people that you bring around the table to either put the data in people's hands or to transform it into a way that it can be usable. I'll give you an example. Yesterday, I met a young woman who is a part of an 1871 tech incubator here in Chicago. And she told me this story of her mother as an immigrant from Ghana. And what fascinates me about this story is the city of Chicago came to a potluck on a Wednesday night in the city of Chicago, where this is probably the best environment for this kind of work. And the city looked at them and said, we need help getting people assistance to public services. In less than 30 days, this small team of volunteers who happened to know how to write code and happened to get data into the hands of people at the city, not only were able to capture a problem around the gauntlet that exists for public assistance, but actually able to flip around a tool to help make an impact on that. So at the end of the day, that tells me that this is only done by collaboration and getting it in the hands of policymakers and those other people. It's about bringing the right people around the table to help tell that story, I think. From our perspective, it's the only way we even live in this data is by bringing partners around the table.
And just to talk a little bit about how we put this together, we have one data guy, and I want to have Matthew give you the credit, Matthew Shackstein, and he actually put this all together for us. So in terms of just, one bright person who can go to the right resources and figure out where those types of data are available and then visualize how to put it together is, I think, well worth the investment.
It is actually one of the nice benefits of living in a highly networked age, that the ability to teach yourself how to code, how to interpret data, how to produce digital cartography. I mean, this is actually all fairly freely accessible at this point. There's been a great move. I was at this conference, I met this guy, the rap star will.i.am a little while ago, and he's a very nice guy. I don't know his music, but he was doing this project to actually teach kids how to code in elementary schools and high schools, and then to link that into interpretive practice, particularly around geographic information systems. So I met a group of kids in East Los Angeles that were working on interpretation of environmental inequities in their neighborhoods. So the likelihood that neighborhoods that are differential based on class and racial and ethnicity characteristics were also at disproportionate risk for environmental impacts, negative environmental impacts. And the kids were remarkable. I mean, they were able to do not just they had to write Python scripts, they had to, which I'm sure that's very meaningful to everyone, but nevertheless, they were able to also make the maps and interpret them and speak very articulately to the problems that they represented. And there's a lot more that you can do. There's a new category of job that's been created. If you go around Silicon Valley, everyone and their mother is now a data scientist. What the heck does that mean? But I'm waiting for like the CSI version of the show that's about data science. And to make this sexy. It's important that people want to do this now, and I think that's actually a dynamic that's going to build on itself.
I'll only make two other points to that. When and where has it been successful, and how do we replicate those things? Measles around the world since the year 2000 is down by almost 70%. Malaria, same thing, 75%. It was based at the time in bringing all the right people around the table, government, nonprofit, corporate, using big data to make plans, setting those plans, and then sticking those for 10 to 15 years. That's a significant number when you think about how many kids, women, the vulnerable populations around the world are no longer have to worry about those types of things.
Thank you. We have time for probably one or two more questions right here in the middle. There's a microphone coming.
My name is Kevin. I'm here with Project Cure. I'm also an information systems major at Loyola University Chicago. And I was curious, what are your current methods for collecting the vast amount of data that you guys are, and how are you structuring the big data and storing the information to create, valuable information?
I don't know if you want to. Okay. Well, actually, I'll probably have Matthew answer that question. Do you want to give Matthew the mic? Yeah. He's actually pretty good at this.
Yeah. So I guess I'll speak to this example briefly. There's been a lot of talk of these open source technologies out there now. These are things that any person can go on, download the code, start using it. So that entire stack that you just saw, all those different maps, all the different layers, we pulled data sources from, I think maybe over 20 different organizations around the world. We have about 10,000 different data layers loaded into this globe now. It's actually pulling in from these organizations' databases. So they stand up a server, they have maps loaded into this server, they make an endpoint available. I can actually tap into that, visualize it, so I don't actually have to go through the work of downloading it all. I mean, it's, terabytes maybe of different data layers. So that makes it easy. They've created standards to do that. More and more cities are actually abiding by these standards, but it's still a very challenging process. I can get into a lot of detail about that. I'll keep it high level now. So yeah, that's the way that this one was done. It's actually using, pulling from like NRO and pulling from the Philippines data portal that goes, down every other day, it seems. It's just one of those things. So yeah, it's kind of building on this community of people that are doing this.
Great, thank you. We have time for one very brief final question right here over here.
Hi, my name is Takia. I'm from Northwestern. I wanted to know how you guys account for error when taking data. I know my professor's talked about this in her travels, how the women will put what's supposed to be there and not what's actually going on. So how do you account for that?
I mean, there's a very geeky answer to that, but I won't go into it. I think one of the ways to think that through is you're talking about the difference between expected and actual results, right? So you have to be able to have a reasonable model of what the expected is. And that can be based on assembly of relevant factors from other sources so that you know when you're seeing some kind of deviation from the expected that's worth following up on. Some of that actually is just data cleaning practices. So it's really just that people aren't necessarily trying to give you the wrong answer. There's just a tremendous amount of error that comes into any kind of data collection system that involves people inputting stuff. And that is probably the greater amount of error that comes in is people hit the wrong box, they hit the wrong, so there you can design that systematically. So you can design against the likelihood of those kinds of errors coming in. You can also look towards systems where you are which are transactionally flowing, and then have your interpretation emerge from transactional flow. So for instance, and I mean automated systems, right? So in the Ebola example, right, there's actually a tremendous amount of population movement that's taking place. One of the ways we can understand population movement is those people have phones. Those phones are giving off signals. The signals can be processed and can be understood. The sending of the signal is happening whether you tell it to or not, actually. So if you want to know where people are going, you have to be able to figure out how to follow the flow of that system. And that's actually just following the data trail that you're leaving behind. It isn't necessarily dependent upon your cognitive selection when you actually go to enter that information into a survey form. That actually then raises a whole different question, because that's actually then a political consideration and an economic consideration in terms of the proprietary nature of that data to companies that run those systems, and access questions and what other people can do with that, because one thing that can be done with that is to stop outbreaks, and another thing that can be done with that is to target populations for violence and other kinds of recrimination. And so we have to be mindful of all of those different dimensions of the social product of data when we go and we design methods and systems and the means by which we utilize them.
Thank you. With that, we
That
are
was the
out of
non-geeky
time.
answer.
But please join me in thanking our wonderful panel.
Hello. Good afternoon, ladies and gentlemen. It's really nice to welcome all of you back to this year's Women's Day celebration. My name is Fumi Olopade, and I'm here today representing the University of Chicago's Center for Global Health. I'm also proud to be an active member of the Council's Women and Global Development Forum. The Center for Global Health has partnered with the Chicago Council for years now, and this is our third year of co-sponsoring the Women's Day event. Originally from Nigeria, I often wondered why we didn't celebrate International Women's Day, but now it's firmly entrenched in the fabric of Chicago. So thank you, NIM, for doing this. So it's a shared vision at the University of Chicago to convene conversations that explore great global challenges, but also to share stories of our success. President Zima and every faculty member at the University of Chicago really want to get our students engaged in global affairs, and partnering with the Chicago Council on Global Affairs has really been a very important strategic partnership for us. This year's Global Health Symposium, like its two predecessors, has featured very exciting leaders working on projects of significance, importance that we can all learn from. I just came from the session on big data, and for those of you who know Chicago, you know we have the roadmap to big data with all of the amazing work being done by universities around Chicago, as well as the Argonne National Laboratory. So it's very encouraging to see so many representatives from different sectors today, and to see such a wide range of generations who care deeply about issues of women's health, who care about the environment, who care about agriculture, food, and how to empower women globally. I hope you have been enjoying the discussions as much as I have, and I hope you all agree that conversations started today should not end today. I'm delighted to now introduce today's keynote launch panel, which will focus on the health and safety for women working in low-wage and high-risk jobs. As many of you will remember, the 2013 Rana Plaza collapse in Bangladesh brought to the forefront the conditions that many workers in developing markets endure. But what was lost in the conversation was the incredibly complicated and comprehensive health challenges facing the women working in these factories. And I know it for a fact because I was in Bangladesh last year. The University of Chicago has a research outfit there, and we have to provide health to mothers and children in these villages. And we opened the first maternal child health clinic when I was in Bangladesh. But the challenges that these women face are really numerous, including concerns of occupational safety, mental health, high rates of infectious diseases, poor maternal health, and sexual violence. The reason we're working in Bangladesh is because thousands of women and children had been drinking contaminated water contaminated with arsenic, and they have long-term health effects because of that. So today, I'm really pleased to have two experts who will help us to discern the best strategies for solving such problems and improving the livelihood of factory workers. You have a full copy of their bios in your chairs, but let me briefly highlight a few points of their work. Our first panelist is Susan Davis. Susan happens to be an alum of University of Chicago, both. So you're going to get I'm sorry. It's Jennifer. You wanna be. It's Jennifer that's the alum. But Susan has been the founder, current president, and CEO at BRAC USA. And she was telling me about how she worked with her president's mother and how she, in fact, had done lots of work in Bangladesh when she was much younger. But now most of the work is done in the USA. BRAC stands for the Bangladesh Rural Advancement Committee, and it's one of the largest NGOs in the world. Their work supports more than 135 million people through community development projects, and worker safety is a key area of their focus. Jennifer is our alum, and I just met her this afternoon. She's Senior Vice President at USG Corporation, the President of International at USG, the Chairman of the Board at USG Boral Building Products, and is on the Board of Directors of Shore Community Services. USG is an international building and infrastructure firm that has a significant history in leading projects related to worker safety. Now, Neve King, Vice President of Programs at the Chicago Council on Global Affairs, will lead the conversation on stage first and then open the floor to your questions. So please join me in welcoming our panelists.
Thank you, Fumi. Fumi was one of our keynote speakers last year for the Global Health Symposium, and she got the most tweeted, she had the most tweetable quote, which was, "Where you live shouldn't determine whether you live." So a great message, and I think in keeping with our conversation today. Thanks, Fumi, and thanks to you all. Well, I'm delighted and honored to be up here with Susan and Jenny, two fabulous women. And you know, when we first thought about how we'd frame this, not everybody knows about Rana Plaza. I don't know how many of the audience have heard about it. I think we all recall when you hear about the stark numbers of women that died on April 24th, 2013, nearly 2 years ago. It was the largest, I want to get this right, the deadliest accidental structural failure in modern human history. And we just wonder how this can happen in this day and age. So I think we'll kick it off with Susan. Maybe you can just kick it off by telling us about BRAC. We got a little bit of a background from Fumi, but provide some context about how your audience there interacts with the Rana Plaza event, and specifically about how it affected women and children.
Thank you so much, Neve. And I'm really thrilled to be here. I thought the morning's panels and discussions were so stimulating. You know, mental health is something that became a global issue front and center when we were all dealing with the trauma of watching the World Trade Center collapse. I dare say that every one of you can tell me where you were when you heard about 9/11 and those images. Now that I've even just said the word World Trade Center and 9/11, you're seeing it fall. Rana Plaza was Bangladesh's 9/11. Need I say more? I think maybe I should just tell you, BRAC had one of our bank branches in the building, the 8-story building, not 110 stories like the Twin Towers that I worked in, but 8 stories. And the day before, April 23rd, there was a crack, a visible crack on the building wall. And so our branch manager said, we're not going to open tomorrow. And as a regulated banking institution, a commercial bank, called and had to report into the central bank governor that regulates and said, there's a visible crack, we're not going to open. And the other stores there closed down as well. So we evacuated. People are, you know, smart. If there's a visible crack, you don't. What happened is the illegal top 4 floors of that building had garment factories. Those women who worked there, it was towards the end of the month, If you did not show up and go in that day, you will not be paid for the entire month. So on the morning of April 24th, everybody was outside and saying, I don't think we ought to go in. And the guys who were hired to intimidate the young women workers, because we're talking, 90% of the industry, 85, 90% of the 4 million are female, and basically 92% are all under 30. There are very few old women with strong voices that get left in the industry. And so as they were told, you either get in that floor, get up the floor and get to work and meet our deadlines, or you won't have a job and you won't be paid. And, everybody's got to die. And if today's the day you're going to die, then so be it. Literally reported. So what happened is they went in, they took the risk because they've got families to feed, and they thought, all right, let's roll the dice. And as typical, the power went out, the generator kicked on, the whole building started shaking, and it came down. And that's what happened.
Wow. Jenny, USG is involved in building structures and industry all over the world. Can you talk to us about your particular interests and your company's particular interests in this discussion?
Thanks, Neve. I think there's two areas that USG feels that we're a leading voice in these types of just horrific situations that unfortunately Rana Plaza is not even close to the only one of these that happens in any given week, month, or year. USG, our number one core value is safety. We've been a leading voice for safety in the workplace, and we don't view it as a program. We don't view it as a set of metrics. We view it as every single person's responsibility every minute of every day. We've been a founding member of the National Safety Council. We have manufacturing facilities in 17 countries around the world, and it doesn't matter where you are in the world. We feel that as an employee, safety first needs to be ingrained in the way that you approach your jobs, and that you have a responsibility to point out things like cracks in the wall or some liquids leaking out of a tank or a lot of water sitting, or even a little bit of water that somebody could slip on. It gets down to that simple, because if you ingrain safety at that level, then this type of intimidation and these types of situations are less likely to happen. The second place that USG really feels that we have a voice is as a leading supplier in the construction industry, in the building materials world. We invented sheetrock, but it's not our only product. But the great thing about sheetrock and gypsum is gypsum doesn't burn. And so fire safety, structural safety, having integrity in the building process is essential. And it's something that we've been a leading voice in, not just here in the United States and North America, but in setting codes around the world.
So, Jenny, since you're in this business, what kind of events, seismic events, what makes buildings collapse?
So there's a number of things. I think, first of all, every building starts with coming up with some level of design. And when you're designing a building, you need to think about the structural safety. And then you need to think about fire safety. And so the structure is starting with what's the type of land that it's on. Are you building the foundation correctly? Then are you creating those separation walls, those curtain walls? Are you thinking about all of the events that could happen in that region? Seismic, hurricanes, wind loads, rain, and there are all sorts of factors. And then once you've designed the building to carry the weight or carry the structural integrity, then you need to think about within the building, how are you partitioning those interiors? Is there easy egress to get in and out? Is there fire separation walls? We run a lab, a testing center up in Libertyville. It's one of the foremost in the world, and we work very closely with UL to set the right standards for fire-rated walls. Is it a 1-hour fire-rated wall? Is it a 4-hour fire-rated wall? Why do you need different ones? And what are the right products and the right systems that you're putting in place in the architecture and design of that building? And I'll tell you, our frustration is, as much as I love the beautiful buildings, I was just in Dubai this week, designed by SOM or Smith Gill or any of those leading architects, you don't need a leading architect to come up with the right solution to build a building that is structurally sound and fireproof. It's something that has proven time and time again that there's standard ways of doing this, and we feel very, very strongly that in any country in the world that you're in, where you live, where you work, where you play, should be a structurally sound facility, and you shouldn't have to worry about whether or not people are illegally adding extra floors to the top of that building or creating an environment where it is unsafe to your health.
Great, thanks. Susan, maybe you can bring us back to Bangladesh and that region and kind of describe what the working conditions are like for women in this part of the world.
Sure, thanks. And I just want to say what a thrill it is to be on a International Women's Day panel with somebody, you know, who's a senior exec in a construction company. I mean, isn't it like fabulous?
If I can chime in, I'm frequently the only girl at the table, so it's kind of nice to have amazing women
Jenny
around
told me she was, the girl that did math and science, and it somehow didn't get stomped out of her. So, let's keep the STEM and STEAM. And anyway, buildings collapse everywhere in the world. I live right around the corner from the Triangle building in the Flatiron District in New York. And, our famous fire, the Triangle Shirtwaist Factory, has a little connection to International Women's Day. And we needed to have union organizing and a lot of economic and social development to improve our standards that you're proud to tout. And in Bangladesh, my colleagues, they build a lot of buildings, a lot of safe buildings. Brack Tower is a 20-story building that's done, just fine. Grameen's got towers as well from the initial 5 floors that people built when I lived there with the Ford Foundation back in the 80s, as Funmi was saying, when I was a young woman. And I've watched this, the construction with bamboo and head loaders and a lot of day labor produce a lot of very safe buildings. What happens, though, is this problem of corruption. As I said, there was illegal 4 stories added, and that's what happens in countries that are still poor with weak governance. Now, Brack grew up in a country that was just born. 1971, if you remember, there was a war of liberation, and the east and the west of Pakistan split, and the war left a new country with everything broken and a lot to do, with over 3 million killed, 1 million of women raped. It was just like everything. So like most young people probably here in the room, and thank God for all you young people in the room, Abed, the Sir Fazli Hassan Abed, and a group of friends created a committee, the Bangladesh Rehabilitation Assistance Committee. Never intended to make it the largest anything in the world. He used his own money, having sold his flat, and started to try to help, to respond to suffering, started with relief and health care. What happened is he couldn't turn his back because the work was not easily done or easily solved. Things are connected. The fact that people weren't literate meant they needed education. They needed to actually have income and jobs and a source of livelihood to improve their health care. And we got into these circular, interconnected issues that you've been talking about at the conference today, how poverty is directly related to, of course, opportunity. It's not that people were too stupid to stay out of the building. It's they didn't have a good set of other alternatives or options. So Brett got in the business of trying to create wider opportunities, believing that talent's equally distributed, but opportunities sure aren't. And as Funmi's quote was reminding us of. And so what Brack did is create really an enabling organization that helps people unleash their own creativity and power. And in Bangladesh alone now, it's this remarkable, huge institution that has today, I think, an $832 million operating budget, 70% of which is self-generated by the the interest on the loans that those 5 million plus women repay, or they pay for the seeds that they plant or the chicks that they raise and hatch. They've created like the Bloomingdale's of Bangladesh and have a dozen outlets that sell beautifully hand embroidered products. And so there's 120,000 employees in the BRAC network now in 10 other countries too. But part of what BRAC is trying to do is help people help themselves get out of poverty. Now, the garment industry has been one of the most important forces over the last, well, now almost 3 decades. And as an employer of young women, I mean, please God, don't do anything that helps shut it down. We need those jobs. Those young women need those jobs. And so part of what BRAC has been trying to do through the hybrid social enterprise that it runs and BRAC University that it operates in Bangladesh is to help the government, the employers, the brands figure out a long-term solution, as well as just respond to the immediate trauma, the health needs, the mental health needs, the safety and working conditions. And so we've been trying to deal with the victims, because there were a lot of people killed and a lot of people injured and a lot of people who lost their primary breadwinners. And if you've not ever watched a video of somebody telling the story, I mean, there's tons online from BRAC and other people. This is by the big brands, by Gap, Walmart, all the European brands, CNA, they say this is the end of the line. Labor wage arbitrage has hit the end of the line. There's just not a lot of other places we can go and exploit cheap labor. So maybe we gotta fix it. And that's what's going on right now in trying to figure out how do we drive out the bad apples. So use positive deviance to, in fact, reward good performance, create a new generation of ethical leaders and managers who actually have the same conviction and passion that you all have here. And let's figure out how we try to drive and root out the illegal subcontracting practices where a lot of it happens.
Yeah, and I think that segues nicely into a point Jenny made about safety first. So I'm struck by the fact that here you've got the fellow working at the BRAC Bank who's got the sense to say, like, there's a crack in the wall, my colleagues and I won't bother to come in. And they did have to go to somebody, because it's a commercial bank, to say we're closing down. And was it just the heavies that were telling the girls not to, that they had to go to work? Like, how do you instill the safety first around the world, that concept? How do you spread it? Because it's got to be different if you're in 17 countries.
Yeah, for us, we feel that it doesn't matter where you are in the world, that you follow the same safety standards. So it starts for us in the United States. We're one of the very few companies, manufacturers, who have opened our doors willingly to OSHA so that we could win the OSHA Star Safety Award in 17 of our locations.
Maybe you'll tell people what OSHA is in case.
So the Operational Safety Health Association of the government. So they're the ones who monitor the safety and health of factories, and typically many manufacturing companies dread OSHA coming through the door. They think that it's going to add cost and add headaches and add checklists, and they're at risk of shutting down. We as a leader have opened our doors and said we want to win these awards. We have one of the best safety records in the world for for any industry, not just the construction industry. And so we've taken that philosophy based here in the United States and translated that to all of our 25 factories outside of the United States. And actually, 25 factories in Asia, plus what we have in Mexico, South America, and Canada. And there's lots of examples. We were just talking the other day about an example of how this permeates through the community. We discovered a situation in Vietnam where customers in our industry are the ones who we would load their trucks. And so they would essentially tell us how much of what product to put on each truck. And of course, there's laws about around health and safety, around how many pounds, how many tons you can put on a truck. It's a very common practice we discovered in our industry for our customers to request that their trucks be overloaded. And we heard an instance of a truck that was overloaded, losing its brakes on a hill about to roll backwards into a school bus. Now, fortunately, not one of ours, but nevertheless, we realized that, and fortunately, everyone came out unscathed. No children were hurt, so, but again, this is where factory safety goes into the community. We immediately announced that this practice was no longer going to continue under our watch in our plants. And there were a lot of concerns expressed from the local community, from the local workers in the plant, that this was going to harm us because we weren't going to be as competitive because everybody does it and we didn't care. And as a result, what we've heard is that our competitors are following the same loading practices policies. Now, in this instance, most of our competitors are also Western companies who understand the need for health and safety. But it's those types of practices that have to be, forced into the plants. People need to understand that they will be held accountable and terminated if they don't follow the rules, and that it protects not just them as workers, but the entire community. And I think time and time again, the more times that you can train people, is that the way you would do it if your child was watching you? Would you stand on that unsafe ladder if you were teaching your son that that's the way that you fix that piece of equipment? Did you lock out, tag out? Did you turn off the electricity? Did you make sure that when you're walking by that open pit, that there's actually not just a chain going across, but a physical barrier to prevent someone from tripping and falling in? I mean, every small step of the way leads to safety. And the more that people expect that they're in a safe work environment, then the more that they will bring that home. I have a couple good examples. Before I joined USG, I was at IBM. I was not in a manufacturing plant. I was on the technical side. And so I really didn't think much about workplace safety other than I took it for granted. I joined USG. I had 2 different plant managers working for me, and they each, on separate instances, felt very comfortable pointing out to me, their superior, of an unsafe practice that I had done. One was an example. We were facilitating a meeting. I was hanging, just pieces of paper on a wall, and I stood on a chair like one of these. And he stopped me and said, "Jenny, if you were in a plant right now, I might fire you on the spot." He said, "But I'm just going to write you up." Because it was we call them accident no injuries, which means there was an environment where an unsafe work act had occurred. Fortunately, no injuries occurred. And we believe in a safety pyramid, that the more ANIs that you point out, the more aware you are of your environment, and that reduces the number of first aid incidents. It reduces then the number of lost time injuries. It reduces then the number of fatalities. And so if you're not looking around spotting those small things, then you will end up overlooking the things that lead to the fatalities. So it starts with the very simple step. And I'll tell you, the other example was a separate plant manager. We were in Cleveland. It was a freezing cold, rainy night, probably like, last night on the East Coast. And we were walking we'd been at the plant all day. We had checked into the hotel, and we were walking across the street to dinner. No cars on the road. And I started to jaywalk, and he grabbed me by the arm and said, "Jenny, remember, there is no act that is so important or so urgent that it can't be done safely. Wait for the light to change." I was ready to wring his neck. But he was 100% correct. And so again, I think the more and more aware people are of safe work practices in very small things, the more it translates to larger things and prevents terrible tragedies.
Jenny's a troublemaker. We find that out.
I'm the rebel.
A quick question before we move to women's empowerment and goal setting to keep with the theme of the day. Why are they all women working in the garment factories?
They're not all women, especially managers and supervisors are male. But why? And now there are some men that are recruited as sewers or cutting and trimming and stuff. But the dominant reason that young women have been hired preferentially in the industry is because they're easier to control. They have fewer options, and they're willing to not be troublemakers. The threat of sexual violence is easy to use, and actually the execution. If one of the recent health studies that I looked at is the number of abortion-related complications that happens because young women often resort to abortions from incidents of rape and sexual violence. They're also abusing contraception because they're trying to avoid actually having a period because the toilet facilities are so poor. I mean, menstruation is probably not supposed to get talked about over lunch, but I'm telling you, in terms of women's health issues, especially young women's health issues and issues in the factories, it's so important. Why young women are having a lot of health complications is because they don't drink enough. I mean, if you look at anemia, I mean, there's probably a lot of doctors in the house. You know, if you're visiting countries that don't have a lot of good toilet facilities, or you're not, you're on your road trip, what you do, right? Right? You're restricting how much fluid that you're going to consume. You're worried about that, right, women? Yeah, we know about that. We know that the right to good sanitation is one right we have not yet won anywhere really on the planet. We're doing a little better. Thanks God for Starbucks and McDonald's letting us, right? But seriously, the water and sanitation, when Funmi introduced us, she talked to us about how a lot of the health issues are because people don't have safe drinking water. So either you don't have a source of clean water, and there's a lot of diarrheal disease, or you don't have places to use the toilet, and that leads to all kinds of health consequences that are related to then not having enough or the right nutrition. And so you're looking at that combination of we can get them cheap, we can intimidate them, we can prevent union organizing. We also want to help empower young women. We want to create pathways for economic and social empowerment. So there are lots of positive reasons to hire young women. I don't want to say stop hiring young women. It's just part of what we have to do is understand that, well, one, we've been there before too. The conditions in New York City garment factories are not exactly rosy still, but they were horrible 100 years ago. And part of the health issues, so one is a set related to the industry and the factory environment. Their health and safety issues directly related to the ergonomic injuries, right? Standing too long on your feet gives you what? Backache. Oh my God. And so nurses know about that, and now they wear those nice rubber shoes, and we've got all kinds of different kind of flooring. And well, our computer industry, and we call them tennis elbow, but really it should be like swish elbow from our Android phones. So all of those things that we're learning about how our bodies work in relation to the movements, they're all those injuries that happen. But the big class of stuff is related to age, gender, and poverty.
Yeah. We're a little short on time, so I want to make sure we move to solutions and empowerment, because that's what a lot of this is about. So maybe, Susan, I'll go back to you. What do you think are some of the priorities you have in mind immediately? You've touched on a little bit of a few of them, but I know you worked with the foundation to help the workers that were injured and their families of those that were killed. Are they also setting up priorities for changing the situation? Can you talk us through that a little bit, please?
Yeah, so short term, what we need to do is finish the Rana Plaza Trust Fund fundraising. $30 million is needed, the ILO estimates, to be able to provide compensation according to Convention 121. $21 million has been raised, so there's a $9 million shortfall. And if the Estrella Lesbian Action Foundation can be listed as donor number one, I don't know why all of us can't contribute, quite frankly, along with Walmart and Gap and everybody else that are there. The compensation needs to be provided, and we need to heal the wounds and do the right thing there. Secondly, the government and the ILO and the industry have started a longer-term conversation about creating a new permanent accident insurance system, so that there's a Social Security disability in a standard way, because nobody wants to go through this, you know, put the tin cup out and try to beg, borrow, and raise donations to deal with these tragedies. So figure out how to prevent it and institutionalize it. And 3, everybody's looking and trying to figure out value chain improvement processes. The industry in North America organized the Alliance for Workplace Safety in Bangladesh. The Europeans and the industries organized something called the Accord. They've got a lot of initiatives. They've been bringing in fire safety doors that hadn't been available and all kinds of very practical things like that. The long-term solution, though, is cradle-to-cradle thinking. Cradle-to-cradle thinking is where we shift from and take full responsibility for the stuff we make. In fact, it's shifting from a story of stuff to a story of life. And just to give you one example, Timberland, you all know the shoe company, they for the first time bought a tire company, and they're going to put their brand on that tire company. Now, why are they doing that? They are going to buy back the used tires, and they're going to put those tires as the soles on their boots intentionally. Now, you've probably all seen in poor countries kids wearing, sandals made out of old tires. For the first time, they're going to use their brand to do it. An intention for cradle-to-cradle thinking is how the big shift happens long term.
Great, fascinating. Jenny, what about in the private sector? What do you think, what are you guys looking at or are you thinking about to push out now that'll be beneficial to women?
So, well, not just to women, but I think to all workers, and probably around the world, our female workforce in our plants is somewhere between 20 to 30%, depending on what part of the world. So we do have a substantial number of women, but not obviously as many as in the Bangladesh garment industry. But we feel very strongly that workers should be comfortable raising their voice, calling a hotline if they feel that there's an unsafe work practice. And then when you look out into our entire industry, we are working very hard with code bodies around the world, starting in the United States and in every country, setting those standards. And then it's very important for the expectations to be set that those standards will actually be adhered to. And not just standards in the actual architectural process and the construction process, but also in our industry, that if a package of drywall says that used in this system is going to have a 2-hour fire rating, that the manufacturer didn't take shortcuts and leave out those key raw materials that are expensive that help improve that fire rating. And so holding everyone accountable at every step of the way. And then getting back to we talked about the illegal additional floors on buildings. It's astounding to me how often you see this and how much corruption exists, overall in the construction industry. There's a humorous example of this that's easy to look up on Google of in Beijing, a wealthy Chinese professor not just added on to his penthouse apartment, but built a mountaintop resort. And when you see the picture of this, it is this enormous rock mountain with, wall climbing and tons and tons of dirt. Hundreds of millions of tons, I'm presuming. And so now the people in his building are complaining that there's cracks in their walls and there's leaks in their pipes. And you know that this is not sustainable. But I can't imagine driving by this building every day and not pointing out that there were no permits. Somebody was obviously on the take. And you see this all over the world. And so we were talking about over lunch the Foreign Corrupt Practices Act and how important it is as American and Western companies, not just American, because every country has laws around anti-corruption, and making sure that you have full transparency across your supply chain and that you're not tolerating corrupt acts. There's absolutely no need for it, and it's very welcome in many countries that you're seeing more and more of a crackdown, but we've got a long way to go on this.
Jenny, do you guys ever work with nonprofits? You work with coding organizations, but in your factories, how does that work at all for safety or with women's issues around the world?
Yeah, our work is more, we do have the USG Foundation, and so we're very focused when, we're very involved with the Red Cross here in the United States in health and safety events. Also, whenever there's disasters around the world, Philippines, Haiti, we do mobilize our foundation, particularly to help rebuild the communities, both immediately as well as for the long term, so that those buildings in the future are safer and more secure than they were during the initial natural disasters that happened.
Great, thanks. Susan, you mentioned that like this is the last stop for cheap labor. And I was astonished when we were talking in the green room earlier that these young women and others are making, they got a rate, it was doubled recently. They make $70 a month. And some of the fixes that you mentioned seem really inexpensive by anybody's standards, but keeping in mind that it's $72 a month they make, is that right? Can you talk to us a little bit about that? Like what other ways you're fixing it, and also, if it is really true, where else is this happening in the world, even if Bangladesh is the end of the line for cheap garment workers?
Right. So the average wage is 7,000 taka right now in the industry. So I think it's about $78, $79. And well over 60, 70% are making less than that. So you really do have that $1 a day and not quite $2 a day syndrome. The ILO estimates 3 taka a worker a month would be what's needed for this new accident disability system. So that's like a nickel. An average worker will spend about 500 taka of her average 7,000 taka on health care monthly. Often they might get a 200 taka allowance. So, I mean, overall, the importance of what union organizing is doing, but especially female-led union organizing, trying to stay out of the politics, because it's not always really representing worker voice and agency, but trying to organize so that you get a better deal, and working with the progressive factory owners, especially there are a lot of second-generation factory owners. You know, they went to probably University of Chicago and Harvard Business School and all of that, and they actually, they're doing it differently, want to do it differently. It's, you know, factory owners and workers are in a partnership. It's not all exploitation. And part of what I learned in firsthand, really, is what the big squeeze feels like. When there's pressure in this system that we've created, this economic system, if you're a publicly traded company, you've got to dance to the first quarter returns, right, Jenny?
Oh, yes, we do.
Yeah, and if you're not dancing very well to that first quarter returns, the people in charge, what happens to them?
There are many unpleasant outcomes.
The eject button is there, all right? So if we are really looking at the chain and going to figure out a different cradle-to-cradle kind of solution, there's points at every part of it. But somebody on an earlier panel said nothing really is for free, the buy one, get one free. Somebody pays that cost. So, you know, my little sister and my niece and her kids living in Cheyenne, Oklahoma. To my surprise, one day they ended up on the front page of the New York Times as the icon of what rural poverty in America looked like. I mean, I dropped my coffee when I unfolded the New York Times. But they love to go to the nearest Walmart or Kmart or Target, because if you can get a buy one, get one free, it means that both kids get a t-shirt and they have something to wear. So we need cheap clothes to be able to deal with our low-income household situation in our communities. And Walmart and other companies are trying to give consumers the best deal. Now that best deal puts pressure on a system, especially if you're using agents, all the way down the chain. And that's why that 12-year-old girl in Bangladesh will say, I'll work here, because her options at home are often worse. And we've got this exploitation chain going on that is in our control to change. I couldn't agree more with what Jenny was just saying. We need to put sunlight on the value chain right? Like seed to table movements are doing, or fork to farmer you were talking about. In every one, it's an evolution of our consciousness to realize that we are all connected. Her health, that woman in Bangladesh, her health is connected to my health, or my kids, or my grandkids, because it is this generational process that we are sharing one planet. And so when I say the end of the line is here, ground zero, I think we are at a point, a turning point, and whether it's the shock of our own 9/11 or the dramatic tragedy of Rana Plaza, I think we have enough clarity about what to do, Neve. I think you have the clarity. You've been orchestrating these beautiful conversations here.
I'll pass on that job, thank you. Well, as we know, it takes a village. We repeat that a lot in this forum, but and it's all related back to if you were in this morning for the nutrition panel, what they were talking about there. It's the cheapest things that you can take a hold of are some of the worst for our bodies without nutritional value. So it all comes around. We have a few minutes for questions, and you wouldn't want to miss a chance to talk to Jenny and Susan today. So if you wouldn't mind raising your arms and just waiting for a mic, we can kick it off. Oh, good. We haven't silenced them all. Table 5, please.
It's not a question, it's a request. Susan, if you'd lead us just in a moment of silence, because your story strikes to our hearts.
You know, that's just what we've been doing with all the victims who survived the Rana Plaza collapse, is teaching them about the peace that can come through breathing. So I'd be privileged to. Let's take a breath together.
Thank you. And I think that could a good time for reflection on a lot of the stories that we talked about today at all of the panels. Do we have any other questions? Yeah, the gentleman over there, please.
Hi, how do you guys see the role of certified B organizations and corporations? How do you see that being impactful in making social differences?
Sorry, could you say I couldn't hear the first part of your question.
B Corps and social enterprises. It is hot. And it's going to be fueled by all of you, young people, who are going to make it happen. We are transforming the nature of business. We invented, right, legal liability corporations. We've got to invent something new to unravel the pressure points in the system. And that is the hope of the future. And if you haven't heard about it, there's a lot of resources about B Corps and social enterprise.
Anyone else? Well, my thanks are a little long today, so first of all, please join me in thanking Jenny and Susan for their comments today. And I'd also, if you will be patient and let me list all of our institutional partners who are doing fabulous work all over the world. The American Red Cross, AmeriCares, Artworks, ASTMH, C2ST, CARE, Chicago Foundation for Women, Chicago High School for the Arts, Direct Relief, Girl Up, the Global Fund for Women, GlobeMed, Grand Challenges Canada, the Greater Chicago Food Depository, Heartland Alliance, the Khalaf Al-Habtoor Leadership Program at Illinois College, La Isla Foundation, Lake Tanganyika Floating Health Clinic, Northwestern University Center for International Human Rights, Pathfinder International, Planned Parenthood of Illinois, Project Cure, Rotary International, UIC School of Public Health, University of Chicago Center for Global Health, University of Chicago Lab School, the Virtue Foundation, and Young Women Leadership Charter School. Thank you. Let's give them all a round of applause. Yeah, it was a great list. I'd also like to thank all of our speakers, moderators, introducers today. They've done a fabulous job. They've come from far and wide. My colleagues, John Macca and Zoe, have been here for 36 hours dealing with booking flights in a way that's kind of unprecedented in council history, but they managed to pull it off without any problems. And then, of course, a huge thank you to our sponsors, AbbVie and USG. Their support of this makes it completely possible. All of our students are here for free. Thank you. You're educating the next generation on these critical critical issues. So thanks to USG and Jenny, Jeff Richardson, and all his colleagues from AbbVie. Thank you so much for that. And then, of course, I'd like to thank you all for getting involved in the conversation about International Women's Day. Downstairs, no, are we downstairs? No, we're upstairs again. Okay, downstairs, you'll see all of our partners are there. And all of these videos are on YouTube. So if you missed any of the panels because you were in the other one, you can pop onto the internet and you'll be able to see it. So you can get out your phones and turn them back on now because I'm nearly finished. Save the date. Is this the right date? March 11th, 2016? Don't save the date. I actually think that's the wrong date. We'll get back to you on that. It's before International Women's Day. And then two more things. Our next two programs that we're hosting at the Council for Women in Global Development Forum, Mona El-Tahawy. She is talking about sexual revolution in the Middle East. Going to be a fascinating program. And May 20th, Helene Gale, who was president and CEO of CARE, she is retiring. She's going to reflect on her tremendous years that she spent at the head of that fantastic organization in a conversation with Kathy Pickus from Abbott. So that'll be fascinating. Now you can get down to the second floor. There's coffee down there. And thank you again to Susan and Jenny and to all of you. Thank you so much. We're adjourned.